Good evening to every valued member joining this session of Spasht 2020. 206 bones, more than 600 muscles. This is the skeletal framework of one of the most seamlessly functioning machines on this planet, the human body. But it is the 306 joints working in rhythm that enables the flawless movements and stability the human body requires. Today, our panel of eminent doctors from all over the country will elaborate on everything from clinical approach to diagnosis of various rheumatoid disorders. Our panelists today consists of Dr. Bhimlesh Dhar Pandey, Chief Consultant and HOD of Rheumatology at the Fortis Hospital in Noida, Brigadier Dr. K. Shanmuganandan, Professor of Internal Medicine at Sri Balaji Medical College and Hospital, Chennai, Dr. Sumha Bhalan, HOD of Rheumatology here at AIIMS Kochi, Dr. Ajit Nambiar, HOD of Pathology here at AIIMS Kochi, Dr. Mithun C.V., Associate Professor of Rheumatology at AIIMS Kochi, and finally Dr. Paramjit Singh, Associate Professor of Internal Medicine at Government Medical College and Hospital, Uttarakhand. Today, our moderator for this panel discussion will be Dr. Colonel Vishal Marwaha. He is a graduate of the Armed Forces Medical College. He did his MD in General Medicine, his DND in Internal Medicine. He completed his long-term postdoctoral fellowship in rheumatology from AIIMS Delhi, his short-term fellowship in City Hospital and Queen's Hospital, Nottingham. He has served in the Indian Army for 28 years as a true patriot. Sir's father, elder brother, and 4 of his uncles have also served in the Indian Army and the Indian Air Force. He headed the Indo-Bhutan Friendship Hospital in Thimphu, Bhutan early on in his career. He has even served in 4 rheumatology centers in the armed forces. Other accolades to his name include the prestigious Chief of Army Staff Commendation Award in 2012 and the Army Commander Commendation Award twice in 2008 and 2010. He's joined the Amrita School of Medicine in 2016 and has been serving as our beloved principal since May of 2017. As Sir very efficiently juggles his extremely busy professional career, he never fails to inspire us to reach out for our dreams. I'd like to welcome our beloved principal, Dr. Colonel Vishal Marwaha.
Thanks, Henrella. It is indeed very nice that 2 days before the World Arthritis Day, we got this opportunity to have this panel discussion on rheumatic diseases. Good evening to all the faculty and students seeing this panel discussion on rheumatic diseases. Why choosing rheumatic diseases as a topic for panel discussion for an undergraduate conference? I think this is one question many would ask. Dear friends, rheumatic diseases are very common in our practice. But the teaching in MBBS and MD, for that matter, even in post-graduation, is pretty much just about adequate and at times inadequate, depends on the center where you are trained. When I did my MD, I had 3 teachers of rheumatology. But when I was doing rheumatology at the All India Institute, there were, faculty used to come for training with us from some colleges in India, and they used to tell us that they have never had much exposure even during their MD medicine. So, these are things which you all must keep in mind, that if I today ask somebody that, okay, what is the murmurine mitral stenosis or MR, quickly they will answer a 7th semester or 8th semester. But you ask him how to differentiate rheumatoid from spondyloarthritis, they are quite, taken aback. So I think to cover this gap, actually, I thought this will be a good opportunity. So it is with this in mind we embarked on this journey today. We plan to cover rheumatoid arthritis, spondyloarthritis, SLE, childhood rheumatic diseases, and crystal arthritis, which are seen in practice. We wish to make an effort to sensitize our students to rheumatic diseases. Sometimes, people ask, why did you choose rheumatology as a super specialty? Now, nobody asks this question. When we took rheumatology, there were very few people who had done rheumatology. So that time people used to ask these questions, 2002, 2004. Nowadays, nobody will ask because rheumatology is full-fledged. There are DM courses, DNB in many centers in India are offering. One I told you was that we had 3 rheumatologists teaching us. Further, my senior in college, Brigadier K. Shanmuganandan, who is here today with us, took rheumatology as a subject. He was, because when we were doing our MD final year, he had already completed. He was our clinical tutor. So, seeing him going towards rheumatology, and he was very outstanding, student and physician. So then one of my batchmate also, in fact, 2 of us took, and one who went to US also took. So 3 out of 6 in my batch took rheumatology. So that's where the way to go, who is guiding you, all these factors, I think, will play a very big role. So we will start with the order would be the first to speak would be Dr. Vimlesh Dhar Pandey, Senior Consultant Rheumatologist at Fortis Hospital, Noida, UP. He's a very renowned rheumatologist in the National Capital Region. This second to speak will be Brigadier K. Shanmuganandan, Professor of Medicine at Sri Balaji Medical College. Sir would be the second speaker for the day. The third speaker for the day would be Professor Suma Balan, our head of the Department of Rheumatology and one of the most outstanding pediatric rheumatologists in India. Then it will be Professor Ajit Nambiar, head of the Department of Pathology at Amrita School of Medicine, a very learned pathologist and oncopathologist, and one of the finest teachers in the subject. Fifth to speak will be Dr. C.B. Mithun, Associate Professor of Rheumatology at Amrita School of Medicine, a very dynamic and young rheumatologist with excellent clinical acumen. And last but not the least would be Dr. Paramjit Singh, Associate Professor of Medicine and in charge Rheumatology Clinic at Government Medical College, Haldwani, Uttarakhand, a very seasoned rheumatologist who is one of the few rheumatologists in Uttarakhand and gives cover to a very large population. We thank all our speakers for taking time out to be with our young friends. I'm sure this will be a meaningful session, and I thank all the members of the organizing committee and all audience for their presence with us today. So to begin the deliberations, I'll start with introduction of Professor Dr. Bimlesh Dhar Pandey, who is the Chief Consultant and Head of the Department Rheumatology at the Fortis Hospital, Noida. He is a graduate of the Government Medical College, Trichy. In fact, Dr. Mithun was 3 years junior to me, junior to Bimlesh Pandey. And he did his MD Medicine at Ranchi and then went on to do further training in rheumatology fellowship at AIIMS, New Delhi, where he was SR Rheumatology also. He has many publications and orations to his credit. He has also been the organizing secretary for many conferences, especially very active member of the Delhi Rheumatology Association. Over to you, Bimlesh. We'll be speaking on SLE and management of SLE.
Thank you, Dr. Marva. It's indeed pleasure to be with students, and at the end of the day, I can always say that I always wanted to be a teacher, but you gave me a platform to be again back with younger colleagues. And uh, I would just like to, give a brief glimpse that why I took rheumatology as a specialty, and you were already candid about, because my professor happens to be a rheumatologist at Thrissur Medical College, and the subject in which I did find real difficulty was lupus, and I never knew how to understand this various rheumatic diseases. So he gave me a case in the fourth year. It was a complicated case of lupus where there were a lot of findings, and I goofed up with the history. But this lady, young lady with multiple pregnancy losses, also had neuropsychiatric lupus, and she gave everything which I asked in an opposite manner. So, are you married? She would say, no, I'm not married. Already, she has had multiple abortions. It also created a lot of interest. So, I'm thankful to my professor who actually gave us this, specialities full of clinical material, and that's why I took. I'm thankful to you that you gave me a topic, lupus, and here I begin. So, without a history, it is very difficult to proceed. And why this disease is called as lupus, we would like to understand what is lupus. And lupus is nothing but a Latin word for wolf. And why this disease was named as lupus? Because someone observed that some people had a facial rash which was mimicking life as if a wolf has bitten the face of an individual. And this was named by Cazenave as discoid lupus erythematosus. And it was Professor Sir William Osler, an astute clinician, who figured it out that it is just not a skin disease or skin condition. And there are a lot of systemic manifestation of along with this skin disease, and he named as systemic lupus erythematosus. So each word has meaning. Systemic means you have other body systems and organs or organ systems involved. Lupus because it looks like a bite mark on the face of an individual, and erythematosus because it used to have a reddish hue. So what is this disease that we are talking today? So it's actually an autoimmune disease, which is of progressive nature. It has got a lot of chronicity, and it is a stereotype of inflammation with a tissue damage that you encounter. But what is unique about this disease? Say, if you see malaria, so you have a disease which if you don't treat, you end up, someone losing his life in say malaria, but say complicated malaria. But here you have a disease where you can have a spontaneous flares. Disease may come up. There may be a lot of manifestations, and sometimes it may remit on its own, and again it may come back. And you cannot, pick the disease by one or two characteristics. It has got a lot of heterogeneous manifestations. So, just to make things very interesting, so you can have uh, fever as one of the cardinal manifestation, but one odd patient may come to your emergency who had fever some time back, but he is actually having hemoptysis, and probably there's some bleeding in the lungs, a sudden manifestation, sudden flare of a disease. Or someone may come with a skin involvement with a background history of some amount of pain on and off, and weight loss or something. So there are a lot of things. So like an elephant, I would say this disease is like an elephant. You can start an elephant from its tail, from its trunk, from its unique teeth, that tusk we call, or the whole body. So you call it elephant. The way you would see it, still you call them elephant. So lupus is so interesting. And one should understand lupus because it will help you to understand infectious disease, which is the closest mimic of this condition. And one has to become a clinician, needs to observe those clinical cardinal manifestation of systemic lupus erythematosus and various other diseases, and that's it will help you. But there are certain things which are so characteristics of this disease called lupus. So majority you would find it is a women who are affected. So 85% of the whole patient population of lupus would be women. And the worst part is that it happens in a younger population. That means it peaks in the reproductive age group of these women. And not all lupus is bad. So when you encounter lupus, you have to understand it can be organ threatening, which can later on become a life-threatening, or it can be even non-organ threatening. So all lupus may have a different, the way we score marks in our examination. You can get 75, which we call good, and if you get 85, you say fantastic, but you can still pass with 52% marks. So you can have an organ threatening lupus or you can have non-organ threatening lupus, and one has to understand this lupus has got something unique about the genesis. Your genetics is very important in this disease because certain population will have more incidence of lupus. So you will find more prevalence of lupus in certain populations, say Native Americans. White population has lesser amount of lupus. The Asians would have are worse than the white people, but the Native Americans, the African people, and the Hispanics have a good amount of prevalence of lupus in the population. Since I said that lupus is such a unique disease, so you can actually pick lupus from blood test or manifestations of this disease. So why I have chosen this cartoon to represent is what is the most common aspect that you would encounter, whether it's a clinical or lab in lupus. Say, for example, majority of your patients who have lupus would be positive for ANA. But just mere ANA does not mean lupus. They need to have certain clinical features, say arthritis or skin changes or myalgias, which are the commonest clinical manifestation. You can have other odd features. If you suspect some person having lupus, they may have another lab abnormality, say like low complement, high dsDNA presence. So those features you propel you to think about lupus. But knowing that what is common as clinical manifestation will actually make you think what is the next that you should do in a lab investigation to catch them early, because that's very important. So think of arthritis and arthralgias with skin changes, amount of myalgias. Fever is a common manifestation, and you may get pleuritis and anemia if you do a common blood test. And so there are a lot of clinical manifestations, and I have labeled it, depending upon the percentage that in the out of 100 patients. So lupus can be diagnosed based on a clinical manifestation by its manifestation outside. What are the manifestation outside? It is say synovitis, that means joints are involved. Malar rash, which is a skin involvement. You can get oral ulcers, which are so characteristic, but don't think all oral ulcer is lupus because you have other differential diagnosis. You can get subacute cutaneous forms and some discoid rash, Jacquard's arthropathy, which may look like rheumatoid, but they are able to, you will see that if you examine them that they are unique, and those deformities are correctable. And you have vasculitis, and you can get another skin manifestation called lupus profundus, where you have inflamed fatty necrosis due to lupus, which causes some changes on observation. But you can have lupus from inside, which may manifest as pleural effusion or pericardial effusion if you have a luxury of MRI of the thorax. You can get infarct, so you may have a young individual coming with a stroke as a manifestation of lupus, and you can have a chronic lupus manifesting as a form of a dementia or abnormal CNS functions, say brain atrophy. And if you observe under microscope, you can see damages happening in your RBC membrane, where you can see spirocytes, and kidney involvement is so common, and also organ threatening, where we can see a lot of glomerular nephritis. But there can be something called as lupus intangibles, which is like I get pain here and there, and there's a lot of fatigue. Because it's a systemic disease, you get a lot of fatigue. A good number of patients may have depression, and some people just come with some fever, joint pain, and they say, I'm just forgetting these days. I'm just not able to concentrate and remember things. So you can start thinking based upon the smallest clinical information that you get from the patient. So always listen to your patient. And as we know that any disease, you require some amount of genetic, some amount of environmental environment and behavioral triggers. So for example, I said the females are more commonly involved. So the hormones are so important. Certain infections like Epstein-Barr virus in the past can, propel lupus in a susceptible individual who has got a genetic association of this disease, and sometimes sun exposure. We all want to have sunlight for our vitamin D, but for certain predisposed individual, sun exposure or smoking and even stress can be one of those trigger points which can trigger this autoimmune condition called lupus. So what actually happens in lupus is that we lose tolerance to our own nuclear antigens. And because we are unable to tolerate our own antigens, because there's a breach in our tolerance, our immune system goes dysfunctional and they start making anti-nuclear antibodies. And this anti-nuclear antibodies causes dysregulation in the immune system, where there's an immune response, and then you get a clinical manifestation. So you have a susceptible individual with lot of breaches before they manifest in a clinical way. So you can easily understand that lupus can involve anything. So if you start from top to down, this is how I was taught. Start thinking from top to bottom. So it can involve your central nervous system in various manners. It can involve your eyes, your skin, your oral cavity, your thoracic cavity in form of pleurisy and pericarditis. It can involve your kidneys, your muscle, and your bone marrow by blood disorders, and joints, obviously, and you can get some form of vasculitis or Raynaud's phenomena. I'm just giving you brief pictures of how you can remember. So if you see an individual with alopecia, with a background history of fever, joint pain, and ANA positivity, this is what is called as alopecia. So this constellation can make you think of lupus, a young girl with malar rash and a sparing of nasolabial fold, and Raynaud's phenomena. These are something that will help you to identify this condition called lupus. So this is how we move forward from top to bottom. Now we are going to cardiac involvement in form of endocarditis, myocarditis, and pericarditis. So it is so interesting that you can think of any forms of permutation and combination, and you have a constitutional uh, manifestation like fever, fatigue, and weight loss. So easy. Any systemic disease can cause. So even your TB can cause. So it is a clinician job to identify what an individual has: fever, fatigue, weight loss. And GI symptoms can be nausea, which is so common. Vomiting can be so common, but it can be abdominal pain because it can be abdominal vasculitis and some other issues that may happen in lupus. The hematological abnormalities of anemia, leukopenia, thrombocytopenia, or even bicytopenia, or even pancytopenia can be a feature of lupus. The musculoskeletal involvement are basically arthralgias, lesser arthritis, and many times myositis. The pulmonary involvement can be chest pain, pleural pain, pleurisy, pulmonary hypertension because of its chronicity that it involves the lungs, in pulmonary hypertension and pulmonary parenchymal involvement, which may lead to ILDs, etc. And you can get bizarre neuropsychiatric involvement, which can be even renal neuropathies, organic vein syndromes, peripheral neuropathies, psychosis, seizures, transverse myelitis. To see how complex this disease, it can manifest in such a bizarre manner. And in a renal manifestation can be nephrotic syndrome, hematuria on examination of blood, cast in the blood, and proteinuria. Depends upon how badly your kidneys are involved. And then you have got reticuloendothelial system involvement in forms of hepatomegaly, lymphadenopathy, splenomegaly. So all needs to be taken in account, needs to be thoroughly asked by history, and then we move forward. The way of diagnosis is laid by American College of Rheumatology. I'm going with the old time-tested criteria where they say that you require 4 out of 11 criteria to be there in an individual where we can say that they are having lupus, and they have basically 3 skin manifestations like malar rash, discoid rash, and photosensitivity. Very important. Photosensitivity is very important. These are the 3 cardinal skin manifestations: oral ulcers, arthritis, pleural effusions, pleuritis or serositis or pericarditis, kidney disorders, neurological disorders, and blood disorders forms the clinical domain, while the immunological disorders and abnormal ANA and anti-dsDNA or Smith antibodies or antiphospholipid antibodies are the blood parameters that we need. So you require actually 4 out of 11 to say yes, it is lupus in a patient where you have to clinically examine them and make up them. So there's another criteria called SLIC. Again, you require 4 criteria before you diagnose. But what do you do when you have a patient? So uh, you need to understand that you can get a lot of abnormalities to begin with, but the patient may be clinically silent. So, if, for example, if a patient has ANA positivity and had in past, bicytopenia, which is actually recovering, but also has a decreased serum complement, which is of recent. So you can think that this individual who is actually silent, when I said disease has natural relapses, remissions, and flares, you need to understand sometimes you get a blood test which may indicate event that may happen later on. For example, a high level of dsDNA, a very low level of complement, a very high level of ESR, and low hemoglobin, platelet, or leukocyte count, they may all indicate that there can be a disease flare, increase of CPK, which is a creatine phosphokinase, microscopic hematuриas, and proteinuria. These are all. But when you come to manage this, when you have to manage this patient, it's very difficult task because you have to understand management is like a size which fits me is a size which I'm going to wear. So not all the size will fit all individuals. There are different sizes for every individual. So one of the few things that you need to speak about in the treatment is sun protection, some amount of vaccinations for ladies with to be vaccinated by human papilloma virus vaccine, amount utility of exercise, stopping smoking, weight reduction, having correct blood pressures, lipids and glucose, and sometimes you may require antiplatelet drugs if you are, can be required. But most of the patients of lupus are actually managed by hydroxychloroquine, whether they are mild, moderate, or severe. It all depends upon the scoring pattern, which is called a SLEDI, the score system, from which we define whether this individual will take only hydroxychloroquine and small dose of steroid, or they may require even a stronger medication or more yeah, powerful medication. So these are few things that one has to take in account. So glucocorticoid is also indicated in mild disease along with hydroxychloroquine, which can be oral or intramuscular. For moderate to severe disease, not only we require glucocorticoid, we may require oral or IV along with hydroxychloroquine. We also require methotrexate and azathioprine, which can be between mild to moderate, and moderate disease may require a newer form of therapy called belimumab, which is an IV drug. You also require calcineurin inhibitors like tacrolimus or cyclosporin, MMF, cyclophosphamide, azathioprine, etc. for moderate to severe disease, rituximab for again severe disease, and then you can grade, depending upon how serious this patient is. Before you start thinking of lupus and making diagnosis of lupus, you need to understand you have to take in consideration of infections like tuberculosis, Lyme's, or bacterial endocarditis, neurological diseases, can manifest as weakness, say myasthenia gravis, may have NANA also positive. Certain malignancies are a very good differential diagnosis. Another rheumatoid autoimmune disease can, for example, Sjogren can be very close mimic of SLE. And drug-induced lupus is so common that you have to identify from the history that what are the drugs the patient is taking. So drug-induced lupus is so easy. You stop the drug, that lupus is reversible. So a patient with psychiatric disorders may have lupus, and if they are, there is history suggestive of, a thought process to label them lupus, then only do the test. It is a bad disease because a good number of patients may die if they are not treated. So one thing one has to understand, the 5-year survivability is actually in current times is around 90% or more. But sometime back when we never had the drugs, it was very, very poor, pathetically poor. Around 50% of the patient would have died in 5 years. And also know who are going to have a bad time. Male gender is a bad disease. Despite you have a female preponderance, male gender is a bad. Low socioeconomic status, poor patient adherence to therapies, blacks, Hispanic, Asians, lower educational status, high disease severity and diagnosis are all bad indicators. And the prognosis as on today is significantly improved compared to past decades, we should, you know, prognosticate based on the status of disease activity in an individual at that point of time. So, lupus, in summary, my dear friends, is a clinical disease characterized by symptom diversity. You have to understand what all it can cause. This is a disease where you can have lot of flares and remissions. It is a disease where pathogenesis is related to genetic susceptibility combined with environmental and behavioral triggers. The immune dysregulation is characterized by autoantibody production. The treatment is targeted to clinical manifestations and severity of organ system involvement. With this, I would say thank you for patient listening.
Vimlesh, it was a very beautifully delivered presentation, and I think you made it very look very easy, and also you mentioned that there is a lot of complexity. I think that's something. So one thing I think the students must understand that if you get an ANA positive patient but he has no fever, no joint pains, no malarial, nothing, that is not a patient of SLE. And this is kind of like when we were taught, one of our grand teachers, Professor Anand Malvi, always has this ANA positivity in absence of anything. Be very wary of making a misdiagnosing or telling somebody they have SLE. So be thoughtful. That's why he beautifully brought out the ARA criteria and that 4 out of 11. And you see urine sediment. See, all of you must never forget about the importance of history taking always, and basic clinical examination. Finally, even a urine sediment, an active urine sediment, like if you have deformed RBCs in urine, it's so important to know that. Based on that, also you can start the therapy. Kidney biopsy may not be possible everywhere to get it done within a few days. Sometimes you may have to go by the based on simple investigations, not necessarily all complicated. So that's something you all should understand. And SLE is a very important disease. It's very important to diagnose it correctly, manage it correctly, pick up organ involvement. Renal lupus, that is very important. That is where the very important. If you diagnose it correctly, start therapy early when there is activity stage in the kidney. If you look at the biopsy, Professor Ajit Nambiar will definitely cover that. There is a thing called activity and chronicity. Once there is tubular atrophy, glomerular fibrosis, then battle will be much more difficult. But you are picking at the early stage. That is the time when you should hit early, hit hard, and you will get better response. So we now move on to Brigadier Shanmuganandan. Sir is the Professor of Medicine at Sri Balaji Medical College and Hospital at Chennai. He served the Indian Army for over 30 years. He's done his MBBS and MD in medicine from AFMC Pune. He did his long-term fellowship in rheumatology from Madras Medical College. He has been the Professor of Medicine at AFMC Pune and at Command Hospital Lucknow, and later on Professor and Head of Rheumatology at the prestigious Army Hospital R&R Delhi camp. He has also done an administrative appointment at Command Hospital Lucknow, where he was the Brig IC administration. So he has vast experience in rheumatology, medicine, and also HIV care. He has done a lot of work in HIV care also, especially in Pune when he was there. Yes. So I welcome Brigadier Shanmuganandan and request him to begin his deliberations. And as I had already mentioned, he is my teacher and my very respected senior. Thank you, sir.
Video setting is not there. Can you hear me? Hello?
Yes, sir. We can hear you.
Yeah. I think there is some problem in the video. Can you see me? No. Not able to. I'm unable to start my video.
Yes, now I think sharing. Yes, it has come, sir.
It's come, okay.
Yes, sir.
Videos come,
Yes, sir. Absolutely.
okay. I will start today.
Sir.
Okay, good evening. Thanks, Colonel Marwa. And he has been my mentor and guide. Though he is junior to me, I've learned a lot of things from life and about army. All I knew was little bit of clinical medicine. And somebody asked why you went to rheumatology. That is the only last vestige of clinical medicine. Even today, whenever anybody gets stuck, they turn to rheumatologists nowadays to comprehensively retake history, analyze the investigation, and then start. Okay, so it is still a clinical subject. That's why I like it. And we had a wonderful tenure in the armed forces rheumatology, and thanks to my teachers and patients, we are able to do something. So today my ambit is to just give a brief overview of the rheumatoid arthritis current perspective. But what I will do is make it very simple. How do I shift the slide? Yeah, okay. See, we had a patient, 55-year-old doctor, in 1990 when I was just joining the training. He was a doctor. He was a senior agency doctor. He was in the army, and he was a chain smoker. Okay, he was from the third batch of FMC. He came with rheumatoid arthritis with multiple problems. He had liver problem, he had lung ILD, he had a skin pyoderma, and he had vasculitis. But he continued smoking, he had deformity, and he was on Ayurvedic drugs. Okay, so he had multiple complications, and he was under follow-up. But in spite of giving various medicines like gold, steroid, cyclophosphamide, at that time, he died because of some sepsis of the pyoderma gangrenosum. So, so this was my first exposure to a very severe case, rheumatoid. I used to think it is a mild disease. And when I was a medical specialist, I never knew much about rheumatology, so I didn't know really how to prevent this deformity. And this was the story initially. Next slide, can we say? Yeah, next slide. Yeah. So initially, the disease used to progress relentlessly. There used to be both deformity and disability, and patients used to keep having various extra articular manifestation because it's a systemic disease. No cure for it. So next slide. Yeah. Yeah, so we used to have this treatment pyramid. We used to start from simple measures and go to toxic drugs. And but over the years, this has changed. Okay, next slide. Yeah, see now there is an inversion of pyramid. We don't have this treatment at all. We sometimes start with a strong drug and then de-escalate. Next slide, please. Yeah, this is because of two things, early diagnosis and early treatment. Okay, now after 30 years, I saw a patient this month only, 27-year-old maxillofacial surgeon. He had only bilateral wrist pain of 3 weeks. Clinically, he did not have any problem. He immediately got the first test done as anti um, CGP antibody which was high. His ESR was nearly normal, and he had already done the musculoskeletal ultrasound and MRI and came to me. I said, "How did you do all this?" He says, "There's so much of knowledge now. Many doctors know about it, at least in metros, though in rural areas it's not much. And it shows early synovitis. He says, this lady wanted, can I be started with rituximab? I said, no, no, hold on, we don't go like that. He says, once you remove all the B cells, then there won't be any synovitis. I said, we have not progressed that. We'll start with our old methotrexate. She was not really convinced. I said, okay, no problem. You see the second rheumatologist. And of course, there's always a great rheumatologist. He says, shall I Google it? I said, of course, you Google it. Then everywhere she found it's only methotrexate and low dose steroid and hydroxychloroquine, which I have started. So this is the change, paradigm shift which has occurred over the past 30 years. Next. Yeah. So there is a revolution of treatment because of only two things: early diagnosis and biology, and proper use of medicine. Proper use of steroids, proper use of NSAIDs, proper use of methotrexate, and proper use of biologics. Because as you know, everything has its own pros and cons. Okay. So next slide, please. Yeah. So what has happened? That lady said was true. He says, "I have diagnosed it. Why not treat it?" Okay. Yes, he came at this stage with little bit of pain only. This picture shows little bit of swelling, but the case I am alluding to came little early, and before all these changes of the radiology came, so she wanted to intervene at this stage. So nowadays we have a window of opportunity. We have what is called as a early arthritis and early DMR initiation, early steroid initiation, and even early use of biological in certain cases. Next. So see that now there are so many drugs available. Apart from that, the earlier drugs have vanished. We have the gold standard MR, methotrexate. Then we add a biologic, and if that doesn't work, there are other biologics, and of course we have small molecules. So we have a lot of weapons to uh, combat this disease. Next. Yeah, so we know that it is a common major type of inflammatory arthritis where there is a joint swelling. Later on, if we don't treat, they go into erosions and extra-articular manifestation. But the last two in your era, you won't see it because we are diagnosing it earlier. Even in non-rheumatologists and even orthopedicians, they start methotrexate early. So much has been the dissipation of knowledge, especially in the southern part of the country. In certain part of country where there are less rheumatologists and less access to tertiary care, it takes a little time. Next. So why it is so important? It's just arthritis, but you'll be surprised to know 0.75% of population to 1% of population have this. So if you do a mathematics, we nearly have a crore plus of rheumatoid, and the rheumatologists are around 500, possibly it will be more, nearly 1,000 if you consider physicians with special interest in rheumatology. So we are still inadequate to access this problem of rheumatoid arthritis. So next. Yeah. So before I embark upon certain key things you should remember, joint pains is not arthritis, and arthritis is not rheumatoid arthritis. Okay, joint, whenever there's arthritis, because joint pains, everybody will have. Persons working in computers, manual laborers, patient doing sitting work in computer work, and patient doing gym, and ladies doing household work. Everybody will have joint uh, pain, and especially elderly. But remember, if there is feature of inflammation with systemic features, with raised ESRCRP, inflammatory arthritis, and majority is formed by rheumatoid. At this juncture, we should always remember, as Dr. Pandey also said, SLE also can cause arthritis. Chikungunya, which is very common, viral arthritis is common. Gout can also cause polyarthritis, and sometimes reactive arthritis can come with 5 or 6 joint involvement or peripheral spondyloarthritis. So we know what is inflammatory arthritis, we know what is RA. Next, next slide, please. Yeah. So what has happened is this again reflects early diagnosis. Initially, we used to have this ACR 1987 criteria because there are no good tests available to diagnose this. So we used to wait for few weeks or few months, and they said that at least four out of these seven criteria given in the left part of the screen we used to have for diagnosis. So patient is to be diagnosed late, is to be diagnosed as seronegative arthritis or non-specific polyarthritis or inflammatory polyarthritis or all that until the has persistent arthritis, nodules or very high rheumatoid factor or erosion, patient is to be diagnosed late. So various people have made it very easy to score. For example, if there are multiple joint involvement with a high titer of rheumatoid factor or ACPA with raised acute phase reactance, and we can have at least 6 points out of the 10. So we can have even in less than 6 weeks, we can diagnose if there are more than 10 joint involvement and there is a high ACPA positive. Even otherwise, this is a classification criteria like this maxillofacial surgeon I told. She is rheumatoid because there is a synovitis picked up by the ultrasound. Plus, she has got raised ACPA factor and slightly abnormal ESR. So that is also a very early rheumatoid. So not only the diagnosis, even the diagnosis criteria has changed for a early diagnosis. Okay, next slide, please. Yeah. So to add, but the catch is we don't know why you have rheumatoid arthritis. In spite of so much advances in treatment and diagnosis, we do not know why it happens. This is a snapshot view of a very simple diagram, very famous diagram given about 20 years back by Choi et al. Which is easy to understand. If you see, all the cells are involved in the pathogenesis of rheumatoid. We have the B cell involvement, T cell involvement, macrophage involvement, fibroblast involvement, osteoclast, chondrocytes, and lot of various cytokines are involved. So this will also give whichever cytokines are involved, but since we don't know the exact initiating cause or the root cause, we try to hit with various biological. So, though it may look little illogical, how can we target only one biological when there is an interplay or a orchestra of cytokines? But still, what happens is since they are the major cytokines, it's just like dousing a fire. If you douse a B cell fire with rituximab, you will have good relief. Similarly, if there is inflammation, you douse the TNF levels with various anti-TNF molecules, you will have a suppression of the inflammation and reduction of the disease. Next slide. So what happens because of this immune activation, the synovium proliferates broadly or uninhibited. Okay. Therefore, we have synovial proliferation, synovitis, synovial effusion, joint effusion, which because of the inflammation, the synovium creeps into the bone, which is called as spinous, and start eating the joint margin, cartilage, and causes joint damage and therefore deformity. So it is a rheumatoid disease rather than rheumatoid arthritis. Next. So what happens is you have the joint becomes swollen, it becomes tender. You can click next, and gradually in additive manner. Next slide, please. Yeah, next slide, please. Next slide. Yeah, next slide. Many joints are involved. So sometimes what happens, you can have a intermittent flare that is called palindromic. Sometimes it will come and go. Sometimes it will come again and again after many years. It will subside, then after many years it can flare up. That's the remitting time. Sometimes it can be proliferating. Next. So it depends upon the phenotype you can have. In very, very actively working farmers, you can have what type is called as arthritis robustus, where there will be a lot of synovitis, but there won't be pain or restriction of movement, or there won't be any morning stiffness. Next. So, but what is important is your Davidson, Harrison, every book gives pages and pages of extra articular manifestation. But apart from nodules, nowadays you don't see much because of better treatment. Number one. Number two is the disease itself has slightly reduced in the severity over the years due to some unknown reason. And because of earlier treatment, you don't see this except for subcutaneous nodules in certain cases. But remember, you can have multi-system involvement because it's a systemic disease predominantly affecting the joint. Next. So we have seen this is the example of a rheumatoid nodule on the extensor surface. Okay. Next. And because of this, what has happened is there is erosion and leads to various deformities. On the right side, you can see various deformities. On the left side, you can see erosion. Okay. Next. And nowadays, even if it's so much damage, you can this also gives a clue that patients are being replaced even with a small joint because the joint is totally damaged. You can see the third and fourth fingers, the joints have been put with a prosthesis, means artificial joint. Okay, and on the other side, there's a pin being put for alignment. Next. But you should remember, it being a systemic disease, we do see young people with such destroyed joints, especially when they've gone for alternative therapy. Here you see both the hip joints are gone. The patient was bedridden. As you know, hip joint is very important for mobility. Here the hip joint is totally destroyed because of long-standing rheumatoid, and he did not take any allopathic medicine. Next. Yeah, so in the clinic, I showed you a picture with a lot of joints. There are various ways to assess the quantum of disease. Just like you can say the weight of a or a worth of a or a, how much weight a particular product has. Here you can do the disease weighting by various methods. Initially, we had DAS and so many methods. One simple method is by CDAC, where you don't require even in rural areas, and any clinician can do it. This is called as clinical disease activity index. You just count the swollen joint, you count the tender joint, then you see the total global assessment by the doctor or a physician, PGA, and that is the patient global assessment, and evaluator global assessment by the doctor. Doctor gives a score, patient gives a score. How good are you out of 10? So let us say patient says 8 good and 8 bad, that is a disease, and doctor assesses it 6, so 6 plus 8, 14, then about 10 joints are involved, so it's 34, so it's a very, very active disease. Less than 2.8 means disease is inactive, though this is seldom achieved or maintained. Next. So we have seen what is it, we have assessed it, we have seen the complications. Now we'll straight away go into the management. Okay, management is very, very simple. You have to start with DMARD. You have to remember only one medicine called methotrexate is a sheet anchor of disease. The day the patient comes for rheumatoid to a doctor, it should be started on methotrexate. We need not do complicated fancy investigation. At least start on methotrexate, very low dose at 7.5, so that patient is latched on to the fact that this is the sheet anchor drug. This is the drug, I'm going to take it even lifelong for remission. It's a mild drug. It doesn't cause much problem. Next. Yeah, these are the various things. This drug has been discovered or invented by Subbarao, Dr. Subbarao was an Indian American, and thanks to him, we are having this is the baseline drug. It is a very cheap drug. It is a weekly drug. There's hardly any side effect. Anybody can take it. All we need to do it is take it with folic acid once a day on a Sunday. So there are some little lot of side effects shown, but in the doses we use, we hardly get side effects if we use it properly. Only thing in about 20 to 30%, it may not be completely effective in causing remission. Next, this has supplanted all other DMRs. They have come and gone. We do give hydroxychloroquine, leflunomide, sulfasalazine, and other things in an figurative mode nowadays. But this is the sheet method. As a young graduate student, I remember if you can go from this talk with the thing that methotrexate sheet anchor for rheumatoid, my job is done. Methotrexate sheet anchor for rheumatoid, my job is done. So the advantages are too much, and lab monitoring though they say 4 to 8 weeks. In India, many times even 6 months of monitoring is sometimes it suffices in rural areas. Though they say every 3 weeks, at least some CBC can be done. The CBC is automated throughout India. That with WhatsApp, all they need to do is a CBC and WhatsApp the rheumatologist so that there's no problem. Okay, use of technology and automation, we can supplant this problem. Next, we can always combine, as I told you. Okay, next. So next, yeah. So, but what I wanted to always tell is, we always used to be a apologetic group saying that no, 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 we should use biological later, later. But the things are changing. Basically, we know if the disease is strong, we want to take a stronger medicine. So what you just see this timeline from last century, from this century. Initially, there was some activity regarding the rheumatoid. It was diagnosed, treated, steroids and all used. Then from 1950s till nearly 1990s or 2000, there has been only one or two events where which changed the treatment paradigm. But if you see from 2000 till 2020, we have a host of advances. We have various biologicals because of the advances in various biological sciences, biochemistry, bioinformatics, immunology research, all these tripod of subjects have revolutionized the treatment of rheumatoid. Though the caveat, many get well if we give steroids for a low dose, short duration with methotrexate. Most of the mild and moderate cases become remitted for a long, long time. It is for the few who are very angry, like we have some angry people for angry disease, we can use biological. Next. So this is a snapshot view. What is the difference? Basically, this all theory. The only difference between DMRs and biological mainly is cost. If I am giving a cheaper biological, I would rather do use in a more person. There are even safer biological, and we can use with combination. We should not be apologetic to use combination, and both are not separate. Nowadays, both are merged. You have a sheet of DMR and then you intersperse with biology. So some people, they always require balance. Next, depends upon the intensity. So this is a snapshot view of a cost. As you see, two things. Cost nowadays, because Indian companies are little clever, they have managed to maintain the cost at a upper middle class level. But the bottom line is it's still expensive for a normal Indian. So though the cost as compared to the biological of the originator molecules, there is a similar medicine made by India, which is called as biosimilar. It's used approved even in USA and Europe now, because the difference between a biosimilar and original molecules can be up to even 10 times. So you can see the costliest biological cost around 35,000, and this is for 1 year, and others will be costing much less. So what Indians we jugaad or we have the various ways, we give for 2 to 3 months, control the disease. By the time the methotrexate will take over. And absolutely, one need not be apologetic or need not be defensive about this method, because ultimately what is required is that patient should be nearly cured, symptom free, and able to do the activities of daily living, earn bread, and do their activities normally, do their duties, and enjoy their life. So this is able to do it. So we have various biological. We'll just go little bit about it, just a bird's eye view, so that we know what it is. Next. So one we have the main group is TNF blockers. They are like your Android phone. Many types are there, and among the older one we have infliximab, and later we have the etanercept. This is the molecular structure. Then we have the other TNF blockers like golimumab, adalimumab, and satralizumab is not there. Next. Next, yeah. Then we have another group. This is the Apple group. You can say this is rituximab. Those acted against TNF alpha. Here it acts against the B cell. B cell CD20 is a marker. So this is a monoclonal antibody. Next, it is used widely in many diseases because B cell are involved in many diseases. Next. So just to next, you just click one B cell. We have the CD4 20 cell, and we have the rituximab molecule, which will go on block this, so that the B cell is not activated to create problem. Next, abatacept is not available in India. It is a very good drug, but because it was costly, it was not popularized by doctors and the patients, and except in certain government institutions. It's a safe drug. It is acts by affecting the co-stimulator molecule. You can say this is like BlackBerry. BlackBerry also came and went off. It's no more available. So that's a good mobile, but abatacept also is a good medicine. No side effects much, but very costly. So went off. Next. Yeah, this need not teach you. You all can teach me about this because of use in corona. This is the tocilizumab. This is the IL-6. Another one cytokine called IL-6. You can say, you can think it as a Google Pixel. Okay. So I'll always give an example of Google Pixel. So this is acts against the IL-6 receptor antagonist. Okay. So IL-6 is a receptor, a cytokine is there which acts on the cell, which is called as a receptor. So this goes and blocks that receptor. So that the IL-6 when it comes to the cell, it finds it already blocked. Just like when you go in a queue, you go to the gate, you find somebody already standing there and you're not able to buy a ticket. So this is useful in even in rheumatoid. In fact, this is a Japanese molecule which has been very effective, found to be effective. It can be, this is one biological where you can use it alone with even without methotrexate, and it's, we have used it even in first line initially. Now it is there in various guidelines, but in India, because again because of the cost, we use it little later or second line or a third line biology. So we have seen about major methotrexate drugs and biological. One thing I deliberately avoided is to speak about steroids. We can use it low dose for a short duration as a bridge therapy and take it out. That will reduce the inflammation. They'll make the patient come to you again. Okay, you can have a follow up. That is the advantage. Next. And this is a new kid in the block, that is a JAK inhibitors, that is a small molecule. This is again going beyond that at a final common pathway. This for that there is no equivalent. Possibly you can think of some Alexa like device which can do everything. Okay. So this goes in the cells and acted. There are various JAK kinases. Next. of which two are used in the rheumatoid. I have not used much because of the cost. Because of the cost, I have not used much, but in few patients I have used, it is effective and slightly less side effects. Okay, we have two molecules. One is tofacitinib and baricitinib. Others are there, but not coming to the market much. They are also effective in certain places where even the biologicals are great, they are being effective. And if the cost comes down because of the ease of administration, and if the cost comes down, and patient will be more happy to take this tofacitinib and baricitinib because they are more patient friendly and you need not visit the hospital for this. Okay, so this is the new kid in the block. This is also come in a big way. So we have lot of good medicines to control the disease in such a way. Okay, this is to conclude. So I just told a brief overview of common inflammatory arthritis, that is rheumatoid arthritis. So it is a systemic disease. So you have to be little aggressive. But what has changed early diagnosis is imaging and ACPA. That is very specific and sensitive biomarker. So patients are coming to the diagnosis earlier and they are able to reach the final. Thank you.
Thank you, sir. It was a very beautiful presentation of a very important topic, the bread and butter disease of a rheumatologist, rheumatoid arthritis. So I'm sure you would all have got good insights. Sir was mentioning about the pyramidal approach. They used to say that there was a pyramidal approach. Start with NSAIDs, then give one drug, another drug, add on DMRs. There was a very famous rheumatologist, McCarthy. So he said hit early and hit hard, and leave the pyramid to the Egyptians. So basically the pyramid was reversed. So I think that's something which all of you must remember. And methotrexate is very important because its cost is less and you give it weekly. So that's a big advantage. Others are costlier. If you take sulfasalazine, it's 1 gram twice daily. That for a individual patient, the cost for the whole month becomes very high. So that's the huge advantage which methotrexate gives actually. Very important drug. And even in children, madam will be covering well tolerated methotrexate. Even in juvenile arthritis, a good drug to give. So now there was one question. I'll just ask. There some questions. We'll try to see as much as we can. Uh, there's one question for Brigadier Shanmuganandan sir. He says, "What is the medical basis of inheritance of rheumatoid arthritis?"
Okay. So the thing is, it is not like a genetic disease, but what has happened is it is definitely got a genetic predisposition, especially with DR gene, that is a class 2 molecule. So there is something called those molecules will have a particular, basically they are genes, they are sequence of amino acids. They have a QKRAA or a QKRAA, QKRRA, denoting each letter denoting one amino acid. This cassette of amino acids, if they have a particular cassette, they have a particular proneness for rheumatoid because then the auto, we don't know which is the inciting factor. This and the inciting factor and this particular sequence becomes antigenic. So the various autoantibodies are initiated and later on because of citrination it is propagated, but it is not the only reason, though it is not a direct like a genetic disorder, but there is a genetic loading. So it is not that if mother has got, daughter will have, but there is a higher chance of getting a rheumatoid. Okay, so this is a DR4 or DR2, that certain genetic marker are there for rheumatoid arthritis. So that's genetic loading is there. That's all it is.
Thank you, sir. I think that really explained it very well. Basically, genetic loading. It's not like autosomal dominant recessive, that kind of inheritance. So keep that in mind. Now we have the third speaker is Professor Suma Balan, Professor and Head of the Department of Rheumatology. She is a pediatric rheumatologist, an MBBS and MD pediatrics from Jipmer, Pondicherry. She has done her CCST training from United Kingdom. She stayed many years there, then moved to India, and she is basically one of the best rheumatologists, pediatric rheumatologists. I have personally, when I joined as head of department of rheumatology here way back in 16, 4 years back, I was there for about 6 months. Then I became principal. It was the first time I was actually got the opportunity to work with a pediatric rheumatologist because I never had the opportunity earlier. So it was a very unique experience, and the understanding of the disease when you work with faculty who has a who has got training in that subject, you also understand much. So I I was not, as I moved into administration, I've been in touch with her, but although I'm not able to learn as much as I would have liked to, but my our SRs, in rheumatology or doing DM, I think they are very lucky to have a madam here. Her presence is a huge advantage for them and for our postgraduates. It's all a question of how much they want to imbibe. That is very important. Over to ma'am.
Thank you, sir. I'll just start with my, yeah. I'll share my screen. Yeah, I can start here. Yeah. It's a pleasure to be here and talking to medical students. And I think it's, the right thing to do to actually expose our medical students to. So, one of the first things that I encounter is most people are not aware of pediatric rheumatologists. They do wonder, what conditions do we treat? And so a huge number of conditions actually. I've just listed some of the standard indications that we tend to see in our clinic. So juvenile idiopathic arthritis forms a very large part of our work. Children with immunological uveitis, children with connective tissue diseases. You've heard Dr. Bimlesh talk about SLE now. Children with vasculitic disorders, of which the commonest we see in pediatrics are HSP, Knox-Schonlein purpura, and Kawasaki disease. Children with autoinflammatory disease. So these autoinflammatory disorders, they've been recognized only since the early 70s. And we're getting newer and newer diseases added on each year now as more genetic associations are being recognized. And we also recognize primary immunodeficiencies. Pediatric rheumatology is a very young specialty compared to many of the other specialties in medicine. It was first recognized in the US as a specialty in 1973. In India, we actually started a Pediatric Rheumatology Society of India in 2003. So we are really young in the network in that sense. And there have been research networks which have been created abroad in the US and across North America, across Europe. Europe is the PRINTO, Pediatric Rheumatology International Trials Organization. And in India, we are just in the process of creating a multi-center research collaboration in the form of something called PRIZE. Now, when we talk about rheumatological diseases in children, people are very surprised. They said children get rheumatological diseases, but actually look at the load in the world. There are probably about 7 million children globally, affected with rheumatological disease, of which 80% are in Asia and Africa. And sadly, there is the 80-20 rule where though 80% of the cases here, 80% of the pediatric rheumatologists work in countries where 20% of the patients exist. So, there's a huge inequity in distribution in this condition. It's also about 0.1% of all-cause mortality in children. So really speaking, a lot of doctors think that these are rare conditions. My question is, are they rare or are they rarely diagnosed? So, we have a prevalence of 1 per 1,000 in children in JIA. Children with pyrexia of unknown origin, about 10 to 15% of them, the cause is a rheumatological disease. 20% of lupus commences in childhood. And Kawasaki disease and HSP are fairly common problems. But we have um, we have a significant problem where a small number of them can progress to chronic kidney disease. And when you think that 35% of the Indian population is under 18 years of age, look at what kind of guess estimates we have here. So, a population each year, you could be having about 5 lakh children coming up with pediatric rheumatic disease. And how many doctors do we have to serve these people? So, we actually need something like at least 450 pediatric rheumatologists to look after only pediatric rheumatology conditions. But then, we don't see only that. We see children coming with chronic pain. We see children coming with the conditions that are mimics of these conditions. We have to see them. Where do all those go? And what do we actually have? We have about 20 centers in the country where some form of pediatric rheumatology is practiced. Of them, the ones in red, the red triangles are the ones where there is full-time pediatric rheumatology service. The ones in blue and yellow are part-time pediatric rheumatology service. So you can see that the need and what is available are significantly, there's a huge discrepancy there. So when should doctors think about referring a child to a pediatric rheumatology service? So children with joint pain or bone pain, children with uh, joint pain, rash, and multisystem features, children with uveitis, children with pyrexia of unknown origin, children who have recurrent fevers of unclear etiology, and children with pain without a specific reason for it. Now, do we think that these conditions are similar in adults and in children? Some of the conditions are similar, though, of course, treating children is not the same. But some of the conditions, like I've listed on the right hand center, are not similar. They are, they can be quite different in the way they present across ages. And it's important to know that. So, what are the tools of a rheumatologist? Contrary to people who think that we deal in weird and wonderful ways, and we diagnose using weird tests, it's not true. Our greatest tools are history and clinical examination. The one skill that we hone in ourselves is pattern recognition, and I'll show you a few examples of that coming down. We also have to be aware of the clinical course of a disease, because that helps us plan right at the outset how we would treat this child, how to individualize treatment for one child with a disease. Then, understanding the inflammatory and the immunological pathways are a very important part of being a rheumatologist, and handling immunosuppressant therapies safely. Now, for medical students, I must urge you all to visit, go down to YouTube, and download the PGALS um, examination tool. It's a very, very simple, evidence based screening tool for musculoskeletal system examination in children. And it's, just like you do CVS, RS, abdomen, etc., you should also be doing PGALs on every child you examine in your clinical postings. And this will help you recognize the normal musculoskeletal system and be able to pick up clinical signs and features as they happen. They're very simple clinical maneuvers, they're evidence based, and they aim to facilitate diagnosis and referral. As I said before, there are a lot of myths about rheumatology. People think a lot of expensive tests are involved in the diagnostics. But actually, the first thing is history, clinical examination, and pattern recognition. And then only we involve fancy tests. And so we are able to know which patient and which fancy test match up. People think that there is no cure for these conditions. So these are chronic conditions that they can be beautifully controlled, and you can live very, very well with them. There are people doing all sorts of careers in the world who have juvenile lupus, juvenile arthritis, who have so many other conditions, and you could never tell. So it's important that they're diagnosed early and treated properly so that their conditions can go into a state of remission and they can be maintained on that. So why? Why should you have pediatric rheumatologists? Because it is important that when you're treating a chronic disease in a child, you should know how the medicine of that child. So, examination skills, ability to differentiate normal from abnormal. What is the differential diagnosis, which would be different between adults and children? The ability to appreciate subtle changes, impact of growth and development, and most importantly, when not to investigate. So here is pattern recognition. You have a toddler girl. You can see from this that she has contractures of her proximal interphalangeal joints. She has her neck extension is restricted. This is polyarticular juvenile idiopathic arthritis. You can also see that her wrists are swollen on both sides. So this is a straightforward diagnosis when you see this is polyarticular rheumatoid juvenile idiopathic arthritis. This boy, you can see what does he have here? He has enthesitis of his Achilles tendon. And you can see it's there bilaterally. And this is something you can observe when he's walking and you look at the back of his leg. The ankle joint is one joint that is beautifully examined from the back because you will see it if it's full. In this case, the ankle joint itself is normal. What is this child showing? So she came to me with a lot of aches and pains, particularly at the end of the day when she has had a very busy day dancing or playing or something. And she's actually demonstrating hypermobile joints. You can see that she's able to hyperextend and hyper move her joints far more than the average person. This is a condition, it is not a disease, it is a natural condition that causes significant increase in pain in children. And this is something to just reassure the parents about because the children grow out of it as they grow older and get stiffer. So it is not something that needs further investigation in a big way. It is not something that needs medical management in a big way. And it's often confused with JIA because of that. So this is the Baton score. As medical students, you should know the Baton score and the maneuvers that you need to do and how you can actually factually come to a diagnosis of hypermobility. Look at these children. These are all children with various extensive vasculitic rashes. They've all got SLE. So the pattern of rashes can be very, very varied. So this child has got extensive rashes on her face, almost crusting there. This boy has got it all over his body, his front, his back, his hands, everywhere. Whereas this girl, she actually came to us with a epileptic status, and she had encephalopathy secondary to SLE. She has mucositis, as you can see here. And this is the palatal ulcer that Dr. Pandey showed you earlier. Here again, pattern recognition, Gottron's papules, heliotrope rash, and Gottron sign. And this boy had significant weakness. He had proximal muscle weakness. He had elevated muscle enzymes, and this is juvenile dermatomyositis. Similarly, Kawasaki disease is again something that we recognize. It's a purely clinical diagnosis. So a child with very high grade fever who shows non-purulent conjunctivitis, reactivation of the BCG scar, periungual peeling, strawberry tongue and very red lips, and a very irritable child with a unilateral large lymphadenopathy and dorsal vasculitis. So these are all various clinical features of Kawasaki disease, which is a disease that can cause coronary aneurysms if left untreated. Here is another vasculitis. This is Hinox-Schönlein purpura. This is a spot diagnosis. You see Hinox-Schönlein purpura once, you will never forget it again. So a tiny, tiny coalescing purpura, huge in number, usually in school-going children. They can also have edema of the hands and feet like this, which is very painful and tender. They can present with abdominal pain because you get the same kind of purpura and inflammation in the lining of the bowel wall. And it can be an ischemic pain, which can be quite severe, and that needs treatment with steroids. This is oral ulcers recurring frequently, very, very frequently, very, very troublesome. So you can see there's ulcer on the tongue, and ulcer on the lip, and ulcer on the genitalia. This is Behçet's disease. And this is again pattern recognition. Young girl, for many years, she's had a right knee swelling with early morning stiffness, and it has not been treated properly. It's, she's got a long limb as a result of that, and she has apparent kyphosis, which is actually not an apparent scoliosis, which is actually because of the long limb rather than actual spinal curvature. We treated her, injected her, started her on DMARDs, and though she does have some limb lengthening, she's a lot better than she was previously. Oligoarticular juvenile idiopathic arthritis. When you see a child with oligoarticular JIA, again your pattern recognition has to kick in. Look, examine the eye. Do they have chronic uveitis? This is a cause of acquired blindness and it has to be treated very, very aggressively. If you don't treat JIA, they'll land up with severe deformities. They can be wheelchair dependent adults. They can have growth failure both due to the chronic inflammation as well as chronic steroid therapy, which these children were all subjected to. All these children, at the time of this photograph, were 13 years old. All these children were under 110 centimeters, and all these children had significant deformities and had been on continuous steroids for more than 10 years at this point in time. And it's extremely sad. This is systemic onset juvenile idiopathic arthritis, a condition that can cause amyloidosis, a condition that can dwarf, a condition that can deform, and can also cause death. A condition that really needs to be recognized early and treated appropriately. Another oligoarticular JIA, this child has not gone to school for a year because she cannot climb the stairs. You can see that she has a fixed flexion knee contracture. With intraarticular steroids and DMARD therapy, within a month we had her going to school. You can see she's so much better. And this boy is a hero again, systemic onset juvenile idiopathic arthritis with multiple joint deformities and fixed flexion contractures. He has not walked for 6 years. And it took a combination of aggressive medical and surgical therapy. We've got him walking now. So the important thing about all this actually was an outcome study from juvenile idiopathic arthritis, but these are points that are common to all rheumatology diseases. So, what is the predictor of achievement of clinical inactive disease in JIA or in many rheumatological diseases for that matter? It is not the ESR, it is not the number of active joints, it's not whether they are rheumatoid factor positive or not. It is what was the disease duration at the onset of proper treatment. And that is what makes a difference between long-term normal life or not. So to conclude, pediatric rheumatological diseases are a significant load. We need to improve awareness and understanding about this among medical professionals and laymen. This rheumatology itself as a proper subject needs inclusion in undergraduate and postgraduate medical courses, which is very patchy at present. While the numbers of trained professionals are increasing, we really need to increase number of pediatric rheumatologists significantly. We need early diagnosis and early referral to specialists and shared care systems in our country. And we need to also have advocacy to improve access of therapy to patients. Thank you so much for the kind listening. Stop.
Thank you, ma'am. It was indeed a wonderful talk, and I'm sure there will be a number of students who will be motivated now to take on pediatric rheumatology. And actually, there is a major gap, like I personally, I was in Calcutta. I still remember there was a child, whom I treated. I think 9-year-old had juvenile idiopathic arthritis, JIA. Basically, what I was finding, the pediatrician was not able to, understand the thought process. So that is a gap because I think in pediatrics, you should be able to pick up, have knowledge of pediatric rheumatology. So somewhere I think that's what happens when. So this is the same thing when when you will interact with students from colleges where they are not taught much of rheumatology in MD also. They don't have a rheumatologist as an MDT. Dr. Shanmuganandan, Brigadier Shanmuganandan was a teacher in AFMC in rheumatology. Before them, Brigadier Kakkad was there. Then later, Air Commodore Shankar Subramanian. They always had a rheumatologist. Now also, Atal is there. So, like here, there is a rheumatology department, 5 rheumatologists. So, I think a lot, then there are differences. There are some of the medical colleges do not have that type of, but I think it's somewhere, that is where I think the students need to. Like the other day, one student from Karnataka was telling me that they all go to NIMHANS for neurology training. From where they have a neurology department, it's not there, but where they don't have, I think there are some issues. So like what I'm saying, it is very important to improve your skill. And I think what ma'am pointed out was that the inflammation. I remember a statement by Professor Anand Malviya, one of the senior most rheumatologists in the country. He said inflammation into time is equal to damage. So the longer the inflammation will persist, obviously damage will be more. So what time do you pick? If you pick it early, that is why there is one thing, and I noticed there is a thing called, there is a early arthritis clinic. I'm talking of 2003. It must have evolved further in the UK when I was training there. That was very good, because anyone has this problem, he is immediately put into that early arthritis clinic. So you can be quickly evaluated, because the basic idea, the paradigm is to pick the disease early. You have to cut the inflammation as rapidly as possible. More you allow, and chronic inflammation will be slowly smoldering. It is not something which will, catch like fire. Not like that. But as madam pointed out, her last slide, I think our second last slide, where she said ESR won't be raised. What actually is the duration? So everything you may not get. That is where your acumen comes in. So you have to develop the acumen. History taking still remains one of the biggest things. Never forget that. So we move on from here, and thank you, Professor Suma Balan, ma'am. It was a wonderful talk from your side, and I must say it was very inspiring for everybody here and all students, I'm sure, who have heard this. Now we'll be moving on to the next speaker is Professor Ajit Nambiar. He is the professor and head of the Department of Pathology at the Amrita School of Medicine. He will be speaking on lab investigations in rheumatic diseases. He has done his graduation from BJ Medical College, Pune, and MD from the Grants Medical College, Mumbai. Then subsequently went on to do his fellowship in oncopathology at Tata Memorial Hospital, Mumbai. And he subsequently did further training in oncopathology and basically pathology in London, UK, and he is also FRC pathology. He has also worked in Nair Hospital, Mumbai, Tata Memorial Hospital, Mumbai, and Apollo Hospital, Chennai. And he had a 5-year stint in King Faisal University, King Faisal University in Saudi Arabia. He is a very accomplished teacher, and I will now request Professor Ajit Nambiar to please begin his deliberation.
A very good evening to everyone here. At the outset, I think I should really congratulate our young team of the undergraduate batch, at Amrita. These are tough times, but tough times call for tough decisions. And the way our young guns, I would say, are blazing in these days, I really feel proud of them. And they're really led by another dynamic man in the principal, Dr. Vishal Marwa. So I should thank both of them to have given me this opportunity to, be at a rheumatic, disease conclave, so to say. And these are not very easy days for me, because, and especially to be talking here, because this is not something which I really deal with much. But then Sir insisted that I should throw some light on what is my thought process in such areas. And therefore, I thought it is apt to, as he said, to talk about lab investigations in rheumatic disease. So the learning objectives that our outline that we have is basically, trying to have, there are, as I say, for every test, there are certain what we call concept maps. There is a basic understanding on which we build the entire edifice of even a test. Yes, there are many specific tests. Well, their utilities and challenges um, are unknown, and I share some of them. And yes, as we go, when we look at biologics as the treatment options in the evolving world, what is happening on the test front in rheumatology? Maybe a slide or so on that front. So that's what we will look at as we move ahead. You know, one of the things we always say in pathology, the way I tell my postgraduates, pathology is considered the final diagnosis. Pathology is the gold standard. So it means, well, the entire train stops at pathology. But if you ask the rheumatologist, how true is it? He would, I'm sure, Dr. Vishal, Dr. Suma here would beg to differ on that, because there is no gold standard as far as tests are concerned in rheumatology, and that is pretty true. So then why do tests, and why do we get into this? But when you look at it from a pathologist's perspective, pathology is not just about diagnosis. I keep emphasizing this point. Pathology is a process, and it's the way you think about the subject that makes all the change. I remember the famous Bangles pop thing, which said, walk like an Egyptian. I tell my postgraduates, walk like a clinician. Because if you're not a clinician, you're not a pathologist, I would say. Because if you do not think, act, and behave like a clinician, then you will not be able to serve the clinician. So therefore, it is very paramount that pathology encompasses not just diagnosis. Gone are those days, when I was training, the whole emphasis perhaps in our days was, give them the blessed diagnosis. Well, it's not that. It's about, finding out. A pathologist should be curious to find out what is the basis for this whole evolution. What is the etiology behind all this? The pathogenesis. It doesn't stop there. When we give diagnosis, just understand for a patient, he does not need those fancy diagnoses. What he needs to know is a very simple thing. Sir, is this good or is this bad? And what I call prognosis. The job of a pathologist doesn't end there. Today, we have gone ahead and we are matching the clinical doctors, assisting the clinical doctors in trying to tell them, which drug would do well for the patient. And that's the area of theranostics. And so, therefore, anything encompassing all this would be actually doing justice in any diagnostic test arena. Yeah. So when you come to rheumatological diseases and we look at etiologies to rheumatological diseases, broadly we classify them under the inflammatory, infectious, the connective tissue diseases, crystal deposition, and degenerative. It's not appropriate for me to get into any of these because we have so many luminaries talking on each of these entities. So it's not at all appropriate. I think I've lost this. Yeah. Okay. Fine. Yeah. So if you look at the causes for rheumatic diseases, look at this chart, and I think it's cut. I just couldn't fit the whole thing into one whole thing. It just explains to you that what my rheumatology colleagues must be grappling with all day long. It's like a never-ending story there. So rheumatology is obviously not an easy subject. It needs a lot of thought process. And where do we come in is, another thing about it is actually when you look at it from say your point of view as an undergraduate student, and also in general, it's about the 80-20 principle, that though we have so many diseases, actually 20% of those diseases comprise basically 80% of your practice. So you would basically look at the common ones: osteoarthritis. You will see so many patients as they grow old, suffer from that. Gout. I myself, I'm a patient, and sir is my treating physician for my gout disease, and infectious, diseases for that matter. Relatively less common, but all the problem and all the confusions which come with rheumatoid arthritis, SLE, connective tissue, vasculitis are definitely what comprise, the usual 80% of our practice. Yeah. So if you look at the basis, what actually is the paradigm in pathology, and this is a slide which is, I keep showing this slide to every undergraduate, because I guess this is where is the central dogma of pathology lies. And whatever we go around in non-neoplastic pathology goes around this very central dogma. And this central dogma, it's about the normal human and the cells. And well, he doesn't have a smooth life. So he's challenged by a lot of things. He's challenged by physical challenges, chemical, biological, immunological, degenerative, genetic. You keep that going, and all that is thrown into on this poor human cell, and he has to deal with it. And when you look at it purely from a rheumatological point of view, much of 80% of these challenges are basically immunological and infectious. So therefore, what you're trying to do is actually, these are the major players which cause the injury. An injury where? Injury on the cell. So the cell, so the cell gets injured directly by these etiological agents. But, if somebody slaps you, are you going to keep quiet? If you're not going to keep quiet, if that cell going to keep quiet, it's not going to keep quiet. I have used the word response rather because if you look at the definition of inflammation, it's the response of the cell to an injurious agent. Rather, when you go, as I gray in my hair, I think of two words, and I use the word response and react. And these two words are different, because in reaction is a little, can be not appropriate, can be inappropriate. Response, we say, is usually appropriate. So therefore, this inflammation, which is the hallmark of all the central dogma in rheumatology and much of what we are talking today, if it is only response, in spiritual practice, it is supposed to be appropriate. But in our kind of thing, but that's the cause of much of the problem. And much of the problem is because of not it being inappropriate. And it being inappropriate because it goes beyond its beyond its confines, and causes destruction. And in it comes the many cells, the many mediators, all the whole of rheumatology practice and the treatment now centers around these mediators, and trying to, silence these mediators, and understand that if you understand what is the, different processes that are happening in these things, will you understand, what mediators do you now, which biological do you want to play with? So Though it's not a, this is not a slide to explain each this thing, and it's not my today's motive to give you anything or more on that mediators, because I have some other jobs today. But it's a very interesting topic, and it's not a very easy topic to understand. Mediators of inflammation are something which is one of the toughest topics to teach also to an undergraduate. And I love teaching that particular topic, because that is something which tells you the basis of many a thing that today's your clinical friends who are on the treating side are dealing with, and using as weapons to silence the very inflammation process that is happening. And understand that the process of inflammation, which is supposed to actually, we used to say, dilute this and destroy and wall off the injurious agent. Well, that was what was supposed to be the response. But now when you go to react, you start doing what is called collateral damage. It's like carpet bombing. When you go and bomb, you are supposed to bomb a particular target, but you'll end up, destroying things on the sides. And that's what gives you the disabilities. So understand that the injury which is there, it is actually twofold. There is a reparative process also. Body is trying to heal. Body is, the human body is I say, is something which is not really understood. The injury which is there, understand, is twofold. One is the injurious agent and the direct action of the injurious agent and the injury that it causes. But in that middle is that word inflammation, and that inflammation which also gives you the injury. And that is what I call the twofold. So if you understand, the whole of this whole understanding of this whole rheumatology and the diseases, go around this, what I call a very central dogma in pathology, or the paradigm in pathology, as I say. And this is something which I always tell the undergraduates. This is, if you understand this, I think you understand the first few chapters of cell injury, inflammation, repair, which is what we start off when we teach the undergraduates about diseases. So when we come to now coming with so the first understanding is understanding, just a brief understanding of trying to introduce you to the subject, and then coming into the various lab tests. No list here is going to be complete. Let me tell you, my job here is not to give you a complete list. I'm just here to tell you about few tests, which are the usual common tests that we use in our practice. So be that be any test, when we talk about a test being specific and a test being sensitive, because this is something which is very important. We talked about, sir was talking about early diagnosis. So if it's sensitive, maybe it can pick up. But at the same time, if it is not specific, it doesn't help somebody. So therefore, a test has to be sensitive and it has to be specific if it has to deliver what a clinician wants today. So understand that. So therefore, any test that you have, it's not just about the diagnosis. Understand, if you're just interested in diagnosing rheumatoid arthritis and that's the end of the story, you just ask your rheumatology friend. That patient is his colleague for the next so many years on the journey. So just by diagnosing the disease, you are not achieving anything. You're just beginning the process. And that process is about disease activity. So therefore, because it's a chronic disease, the disease is going to have its ups and downs. It will go into remission, it will relapse. And during all these times, this is where it's very critical. Any test of tomorrow is all about trying to predict that particular, relapse in that patient. Is the disease in remission? Is it having a low or a high, relapse rate, or is it, what would be, anybody will want you to know, if you are dealing with an SLE, can I predict tomorrow that you're going to have problem in your kidney? That's the question that anybody will ask us. Your patient of rheumatoid arthritis, will you land up with ILD tomorrow? This is what is being asked. This is the journey. This is a chronic disease. Understand, this is a disease not which is just treated and forgotten. This is a disease which a patient lives with. So when a patient lives with the disease, a test which you get in cannot just be a test which is just to diagnose a disease. It has to be a test which actually also takes into disease activity, end organ involvement, prognosis. So understand that that's what I wrote the word longitudinal assessment. What is longitudinal assessment? This is a disease which is a long, lambi race ka ghoda, we say in Hindi. Because this disease is a lambi race ka ghoda. It's actually not good for the patient. But the clinician who understands this understands that he has to now be with the patient for lifelong and help him through a process. And this is where we have to understand that if the diagnostic test or the progress in the diagnostic test is not also thinking in those lines, then what is the point? If the pathologist thinks that the diagnosis is over, my job is over, let the rheumatologist now struggle with that patient, then I think we are somewhere going wrong. And I tell you the story. I will come to the story which I had in this department when my rheumatology colleagues came to me, and I really went through 6 or 8 months. I don't know. Suma will tell me better how many months of real problem on a test and how struggle I did, and I come to that as I tell you. So understand this. I want you to understand this very important factor, which is the basis of understanding that pathology is not about diagnosis. Pathology is about disease, about patient. If you did not know that, then I think you're doing a big disservice in the field of medicine. As so, don't think that pathologists are just here just for the heck of it. We don't take a subject just for the heck of it. Every subject has got its relevance. If you have not understood the relevance of your subject, then it becomes a big problem, because you never will be able to enjoy and have the passion which drives you to connect to your patients. And that's why I say a pathologist has to be a clinician. Without being a clinician, you will never be a good pathologist. So therefore, moving on to the next. So if you look at this test, and that's a test which I'm sure if you are fourth year and fifth year, in medicine, I'm sure you would have heard about ESR test and CRP, serum uric acids, rheumatoid factor, CCPs, and so many things you would have heard about. So there is also the new generation tests, new generation tests which are there. So this is something which back again I'm coming to that ESR and CRP, and look at that again, inflammation there, because I said the whole basis is around inflammation. Inflammation, the acute phase reactants, and the acute phase reactants, ESR and CRP. This is an inflammatory disease. Much of in rheumatology, most of the diseases are inflammatory diseases. And therefore, if you look at ESR, I'm not going too much into the detail. Again, ESR, something that increase ESR, viscosity, and the number of blood cells. Inflammation definitely will increase ESR, because that's where the whole central thing is of having chosen ESR as your test. But understand that there are also, you're dealing with other things also in a patient. Don't think that the patient is just on inflammation and this is a cut and dry patient of a rheumatoid arthritis. He has only inflammation. Understand, ESR is also driven by other non-inflammatory condition which the patient may have, and therefore may increase his ESR. And that's, he may have anemia, he may have kidney diseases, he may be old, the patient may be pregnant or female patient. All these things also increase ESR. So on the one side, you're using ESR because you're testing an inflammatory disease, but understand that there are other things also which you have to take into consideration. But then why is, if ESR is going to be affected by so many things, why is that we still deal with ESR in our department? ESR is one of our central tests in the department. And that's because, understand, a patient of a chronic disease Amount of money that a patient has to spend. If there are tests which are simple and cheap, and if they are done well, help a clinician, I think there is a meaning in running your ESR also well. So is the C-reactive protein. The C-reactive protein also is something that the test which we do. They belong to the, what we call the pentraxins. Dr. Suma must have told you a bit about the PP, the PRRs. These CRPs are synthesized by the liver, and its transcription of the CRPs is regulated by the interleukin 6. Now there comes your mediator. So understand that is why CRP is an acute phase response to inflammation, to tissue injury, and therefore CRP also becomes an important test. But you understand this now, and this is where my story started at the department. An ESR which is getting flawed, and I was just thinking, and I was actually telling Mithun and Suma, who are my rheumatology colleagues at Amrita, why is that they are so interested in ESR? I never knew this, that people were so interested in ESR, and I was wondering just yesterday, before I came into this meeting, I just asked Mithun again, Mithun, is everything okay? Because nowadays I don't see you complain to me about ESR. So what's the story? He says, I'm fine. So I was, so I wondered in those days, why I didn't know about this. And this is a very important DAS 28 score, disease activity score. And you know what that 28 means? It is, if you look at that diagram, it tells you about the 28 joints. And there is a formula there where you do a DAS 28 score in which the ESR also plays an important role. Apart from, understand very importantly, also the clinical assessment. See, understand, it doesn't mean that ESR is the only important thing. The ESR plays a very important role in that formula. In a formula, if one of the things is haywire and you do your good clinical examination, then I'm not contributing to the clinician, which is not something which I should be held responsible for. So I have to understand, because understand based on these DR28 score, you have cutoffs. Based on a cutoff, you have remission. You can say this patient is in remission. If this patient now, we said this is a chronic disease, and therefore he has low disease activity or high disease activity, there will be cutoffs. So therefore, understand, this is when I understood that my rheumatologist uses the ESR, and he uses it still. We think ESR is an old test. I was shaken actually when I understood that this DAS 28 score is something which is very important to my friends, and therefore we made a very important decision at the department that no, we cannot let down our rheumatologists, and we have to help them and achieve. And I'm happy to say that in the last so many months and years or so, Mithun will and Suma will agree. I hope Suma will agree, because I just asked Mithun about it and they said they are fine with it. So therefore, understand the ESR is of relevance in a rheumatoid arthritis case through the DAS 28 score. The rheumatic factor, rheumatic factor, there's certain things, we do rheumatic factor, but then it's also an autoantibody. Understand, it's an autoantibody. It's an autoantibody to the FC portion of the immunoglobulin G. Now understand that, it is negative in about 30 to 50% of cases. And if it is positive, it can be positive in about 5% of healthy patients. And in a variety of non-rheumatology cases also, like hepatitis C, HIV, cirrhosis, which are also common in communities. So therefore, the relevance, that's why somebody is asking the question, is rheumatoid factor is actually a misnomer, because is it actually a factor which actually decides whether the patient is having rheumatoid arthritis becomes a big challenge. And therefore, there was an pressing need to move away from the rheumatoid factor and get into something which is called the anti-CCP antibodies. And the anti-CCP antibodies are again nothing but autoantibody. Autoantibodies to what? Autoantibodies to the citrulated peptides, which is the arginine is replaced post-translationally into citrulline. So it is this that is the autoantibody. And this autoantibody is, so therefore, if you are combining RA and anti-CCP, maybe you can help. It may be of more relevance to a rheumatologist. And anti-CCP is an important biomarker for early rheumatoid arthritis. See, my clinical colleagues are trying to pick up early rheumatoid arthritis, because if you can pick the disease early, you prevent this deformities. So therefore, it is very important. So anti-CCP helps them in that quest, and understand that anti-CCP, if you look at anti-CCP over the last 20, 30 years, the anti-CCP tests have gone from first generation to second generation to third generation now. At the Amrita, I'm told we use the second generation thing. I'll come down into my next. Yeah, you look at these tests from Abbott. We use the Roche one here, and that is the anti-CCP2. And if you look at this, the CCP, anti-CCP, it's a very specific test. If you look at the last column, you will find that all that column is very high scores. What is the problem? The specificity is fine, but the sensitivity, you look at some of the tests, the sensitivity is very low. So which means if you want to pick up early disease, you are not going to pick up early disease. But look, now, just like you have first generation, second generation drugs, so come you have first generation and second generation tests. So you understand the theme that I'm trying to tell you. If the tests don't keep match up with the problem that the clinician is facing today, then I think this journey is useless. So therefore, to make it relevant, even generation tests are also going from second generation to third generation. And that's exactly what you see. So you now see that you have high sensitivity tests and high specificity tests, which is the new generation test, which is helping people, the rheumatologists, pick up early rheumatoid arthritis, and which is a very important thing. This is just, I'll not dwell on this, and because actually what I wanted to tell you is, because I'm not dealing much on synovial biopsies, I would have loved to talk on synovial biopsies, my pet area, but I don't talk on pet areas. I talk to you about, to suffice to say, because sir mentioned suddenly renal, Dr. Ajit will show you renal biopsies, but that will be too much, in my time which I have been given. I'm sure I've overshot that time also. So I just wanted to tell you, see, when we talk about, what is a biopsy there? Biopsy is just there. You think biopsy is going to be a game changer? Biopsy is not going to be a game changer. Biopsy will just tell you, oh, is this disease suppurative? Is it chronic? Is this granulomatous? So we have thought processes based on whether it is suppurative. We'll have one set of thought processes. When it's chronic, plasma cells, lymphoid follicles with plasma cells, with Panus formation, and hyperplasia, synovial hyperplasia. We have another set of diagnoses. Rheumatoid arthritis is a typical example of a biopsy in a patient of rheumatoid arthritis that we don't usually get nowadays. A lot of biopsies, because it is diagnosed by the clinician at a much early stage, and therefore I did not feel that it's necessary to bring in too much of biopsy into this. See, again, look at these tests. These tests are there, the ANA test and the HLA-B27 tests are there. But you have to be beware of certain things. ANA test is, if it's positive, 30% percent of titers, 1 in 40 titers, in 30% of the population, it's there. So if this is where the clinical sense comes in. If you just ask me to do a test and actually the clinical sense is not there, then unnecessarily we might be going the wrong path. So you have to understand that a test has relevance only if there is a clinical relevance. So therefore, a disease, when you have all these inflammatory arthritis and pleuritis and pericarditis, and you get an ANA test positive, then it becomes relevant. And similarly, an HLA-B27. Back pain is so very common, but that doesn't mean you do an HLA-B27 and everything is ankylosing spondylosis. There has to be a history, there has to be a specific history, there has to be a specific family history, or other diseases with it that we come into that diagnosis and the relevance of it. So therefore, understand that just doing a test, yeah, we can give you a result, but then the clinician has to see whether the relevance is there based on the clinical things that are there in that case. So if you look into SLE, one of the big next slide. If you look at this, when I was at the Apollo Hospital, this was one of my jobs there. And to begin with, it was very difficult, to look under your fluorescent microscope. Let me tell you, to begin with, nowadays I don't see my fluorescent microscope, and Dr. Sita, my colleague, looks a lot about fluorescent microscopes. She's full of fluorescent microscopes, along with Dr. Malini, who looks at skin. We used to do this at Apollo, and we were supposed to say, on the monkey or the HeLa, the cell lines, we used to do this test, and we had to say whether it's a homogeneous, thing. That's the way we used to do anti-DNA. It's called the fluorescence way of finding out anti-DNA, and you look at whether it's speckled, it's centromeric, or it is nucleolar. Nucleolar, you'll just see a dot. You can see a centromere in the center. You see speckled here and see a diffuse one. And from there, you get, diseases which come from there. Go to the next slide, and you can see that, each of those patterns, you can see this in any textbook of this thing. I'm not going into the details, but just to tell you that there is some relevance, and you might see some diseases which have a pattern there. And even from an exam point of view, I think you did better that you see this. I'm not going to tell much on this, but it's there in most books. In your exam point of view, I'm sure from your exam point of view, beware of this. Make sure you do this stuff. And therefore, you come down to the anti-DNAs, and you will understand that this is, when you have, this is where I said, if you do a test just for diagnosis, you cannot actually help a patient. You have to also understand whether the test will have a relevance in prognosis and its longitudinal assessment things. So therefore, when we talk about the anti-DNA, yes, it's if it's positive, supports the diagnosis of SLE, very good. But if you are to talk about the overall disease activity, it is at best modest. It's a modest indicator for an overall disease activity. High titers, yes, higher the titer, higher the disease activity. Yes, there is some degree of association there. Whether you have high titers and you will get renal disease, it's a little on the low side. So the evidence is limited in that spectrum. But one thing is there. So the thing is, if you have the in your longitudinal assessment, if the anti-DNA is positive, does it mean you have flare up? It doesn't usually add up like that. But it is said, I don't have personal experience, I'm sure the clinicians will have, that if you have a rising titer in that, then it is of relevance. So understand that the test can be used not just for diagnosis, but also for prognosis and also for longitudinal assessment. And therefore, this is another test. This is another sure shot, thing which you should. I always hear whenever I go to Dr. Vishal sir's office and he's with the students, he's asking at least 3 or 4 MCQs from here. I'm sure, and I am sure all of you should. So I'm not dealing much on this slide. Just to suffice to say that anti-Smith, I think, is the most specific for SLE. Very sensitive will be the double standard DNA in the diagnosis of SLE. So just to suffice to say that much. Yeah. And for connective tissue disorders, I think the anti-RMP will come. And I know sir asks a lot of questions from there. So beware, make sure that you are reading for, I'm sure all of you are preparing for your entrance exam. I've shown you 2-3 diagrams in which definitely you'll get 100 questions, definitely 3 or 4 questions, and then thank me and sir for that. So about synovial fluid analysis, yes, we do this. And again, this is something which is there in most of your books, that you have this non-inflammatory and inflammatory and septic or hemorrhagic based on the cell count and whether the amount of neutrophil counts, you can get. So I'm not dealing much on that slide too. Next slide. So coming to my last slide on new generation and the future of testing in rheumatic diseases, this is something, this is what, see, everyone, one of the buzzwords now in pathology and in diagnosis is biomarker. do we have the biomarker? And it seems Vectra is coming up with some multi-biomarker disease activity panel, which is nothing but a mixture of so many of these cytokines. I do more of oncopathology, and I know that we have the next generation sequencing which is coming, which is dealing with many molecules. So similarly here they're dealing with many molecules and trying to come up with a multi-biomarker disease activity score. I just wanted you to, because from an exam point of view, I just want the new test in scleroderma is the anti-vinculin, which is nothing but a cytoskeletal marker. And this is something which is new. And we were talking about the anti-CCP. Understand that there is something called the anti-CARP, and that is the anti-carbonylated antigen. This is nothing but, again, an autoantibody. What is the change in this autoantibody? The change is that you have lysine replaced by homocitrulline. So it is not citrulated protein, it is now homocitrulated protein. It's lysine with homocitrulated, and it's called carboxylated protein. So, and now I told you also about the new generation anti-CCP. So these are all the new tests which are coming, single tests as well as multi-dimensional tests, which are all about new biomarkers. This is going to be a big this thing. I'm sure in every 3 and 5 years, you will keep changing the landscape here. And therefore, I would say, to summarize, I would say that to summarize, I would say that yeah. To summarize, I would say, see, ordering a test is easy. I always tell my postgraduates, you want a new test, you order the test. But always remember, why did you order that test? If you don't know the aim of ordering a test, then I think the whole game is over. You don't know why. Are you just doing a test for the heck of doing a test? Please don't do it. Please understand why you're asking for a test, because it's very important why you're asking for a test. Please ask those questions and understand that tests don't stand in itself. I'm speaking in a clinical meeting, and if I tell you that I have all the answers, I think the rheumatologist will beat me up, because they know that I don't have the answers. But a good clinical correlation is necessary with good clinical examination. That's important. But I would say a good clinical examination supersedes a good clinical test also, because that is where now, I think I've heard this over and over again, good clinical history, good clinical examination, and I think you will help a patient. And I would say, as from a lab perspective on rheumatoid diseases, that yes, we can help him, help the rheumatologist, but I would suffice to say that rheumatologists will have to take care of their patients. We can just help them. That is what I would definitely say. So taking testing, and therefore to the lab, to the doctors in the lab who will take up the lab this thing, I want to say that taking testing in diagnostic, take testing in diagnostic lab seriously. I just told you about the story of the ESR and the seriousness with which my rheumatologists look forward to that test. So if I don't take that seriously, I think, remember, there is a patient at the end of the whole chain. And remember that the patient is the king of the hospital. We all come to the hospital for him. To serve him we come. So therefore, it is very important that he is served through our tests, and our clinicians are aided through our tests. So that is what I would say. On to my last slide. So therefore, there are a lot of things happening in this field. Be active, I would say, to all the budding, undergraduates who are here on this. Be active. You have chosen the right field, I would say. Keep your fight. Be passionate about what you're doing, and I'm sure you will do wonders. You will do wonders for that patient who's waiting for you somewhere in some corner of this country. Thank you so much.
Thank you, Professor Nambiar. It was wonderful. I think it was I was actually hearing very, very intently because he's like one of the finest teachers. I told you. So those of you who could, I think, attend this lecture. I was told about 750 people plus are attending on various Facebook, Instagram, and the webinar and all. So it's a good number who are already attending, and it's already one. It's going to be now 2 hours 20 minutes. So I know it's basically overshot a bit, but then there was some plan to teach something. The aim of this exercise was not just to cover 4 or 5 things. It's not like that. We need to give some perspective. This pathology lecture was, I think, a very beautiful perspective lecture, I would put it. You're not going into necessarily everything, but I think he was able, Professor Nambiar was able to tell us the, what is the basis of doing a test and why it is important. Like in DAS score, if ESR you are going to get taken, and if you have a wrong ESR, then your whole planning will go bad. So, Professor Suma Balan was asking, Dr. Mithun was asking. I think they have logically, there is a logic in asking for that, ensure that there is a clinico-pathological correlation should be looked at. And, one of the things, I'll tell you, like, see, when you do a test, you have to, don't do a test blindly asking 20 tests. Just know why you are asking a test. See, when I was at the All India Institute, people are, very financially, a lot of poor people come. Now, you can't keep writing, I remember my SR, my senior used to write only creatinine, never used to write urea. He used to say that, sir, it will, achieve the purpose. So, only SGOT, SGPT, no need to do everything. What are you looking at? If you're on methotrexate, do you have to do LFT? And you can always use your, judgment. And what beautifully I liked was, don't think a ESR or urinary. No, urinary is one of the best investigations. In SLE patients, based on an active urinary segment, we have started cyclophosphamide next day. Not based on renal biopsy. Biopsy can be done later. Sometimes there will be very issues getting a biopsy. But treatment should not. Active sediment means you are grade class 3, class 4 lupus nephritis. You have to be, aggressive with treatment. And I remember one lecture, one of the rheumatologists, Indian origin, rheumatologist from UK in Coventry. He was giving one lecture in British Society of Rheumatology way back 2003. He was telling this point that even in a place like UK, it can take time to get. So, everywhere, it's not that in 1 minute you will get everything done. Those things you all should keep in mind. The perspective should always be very clear in your mind, what you are dealing with. The last, what Mata Amritanandama is, thing like Manosthiti and Paristhiti is very important for all of you, that Paristhiti is like this COVID, no, you cannot change. So if you get defeated and take a back seat, that's up to you. Or like our, 2017-18 batch, they did not take that back seat. They said, sir, we'll do online first. So the energy was there, and then we also took it forward. So it is your, mental makeup. That is very important. You have to move forwards. You cannot, sit and say, "Ki, this has become very tough for me," and like I'm actually, like these are like, because what's we had, in the beginning in the March, our 2015 batch, the batch which is doing internship now, we started 2 months because that was a lockdown period. There was nothing. Patients were also very less. We all know all over it has been like that, especially during lockdown. So we taught them a lot. 2 months we taught them, So I have attended few of the clinics which Dr. Ajit Nambiar also took those on pathology, classes on pathology, especially MCQ based. And what I learned was, it is very important your core background knowledge has to be very good. Like CD3 is a marker of T cell. It's a pan T cell marker. CD4 T helper. CD8 T suppressor. CD1920 the B cell marker. CD1656 NK cell marker. CD5559 PNH. Now, how do you remember it? You have to train yourself. So all of you are going to give this exam. Anti-centromere antibody. Which condition? SCL70, which, so, anti-U1 RNP where, last time my students were going, they came to me, they were appearing after 3-4 days, so they were sitting with me. So I just went through the antibodies with them once. After the exam, they told me, sir, nearly 4 or 5 questions came what you taught on that last meeting with you. So you see, at the end of the day, you know what is coming. You can predict it. This marrow and all these are also basically dealing with that type of training also. So you have to train yourself to answer. That is very important. I thought of, talking a few minutes because after one major lecture, I think if you do not have a break, then assimilating the content of the next lecture would be very, very, difficult for you. So I am just talking a few, random issues just to give your minds a break. And I hear it's around 700 plus is still on combined. So it's a big number. So we should not lose the momentum actually. Like it's not rheumatoid arthritis factor. It is rheumatoid factor. In fact, what Professor Ajit Nambiar pointed out so beautifully. See, it is not, it is actually rheumatoid factor. Some people write RA factor. Even labs I have seen, they are RA factor positive. It is not RA factor. It doesn't diagnose rheumatoid arthritis. So these are, the things you should keep in mind when when you mentioned hepatitis C also, in hepatitis C, rheumatoid factor will be positive, especially if cryoglobulins are there. But that is not a patient of, so you cannot say, because that fellow, so you have mild joint pain, then you will say it's rheumatoid arthritis. No. So, see, you have to go clinically. You have to go with history. What is inflammatory joint pain? Very important. Early morning stiffness till maximal improvement starts, gets up in the morning at 7 or 6:30. Then he says that, sir, the pain is very, I have got stiffness. Finally, at around 11:30, it stabilizes. That means got stiffness lasting 5 hours till up, till it plateaus actually. That is the time. Basic things, we have observed, we have done audits. Like, once I was studying crystal arthritis in uric acid, gout. First acute attack, common drug used, allopurinol, which is actually no book has written. You read Harrison, Davidson, no book mentions in acute attack of gout to give allopurinol. But very common you'll find. They'll write one anti-inflammatory drug, pantoprazole, and definitely they will write allopurinol, which should not be given. So in your exam, they will test you. If you can't answer, obviously that means you do not know the basics of crystal arthritis. So there will be questions, coming your way all over, which will test you. Like somebody may show a, kidney biopsy and then say that, urine there is proteinuria, but no active sediment. And then he says there are thrombi. Basically, he's just trying to see whether you have the concept of antiphospholipid syndrome secondary to SLE in your mind. So that's exactly what I wanted Dr. Ajit to say, but that's a very minor thing. He is covered in a very, very, broad way, a very sort of, I would say it was a very good perspective lecture for all of you who attended. I'm certain that you will definitely take positives out of it. One of my best students, when I came here, very good student, Dr. Jyotisha, she was, doing internship. And I remember, 1 week, when I interacted with her, I found very, very bright, She cleared and she joined pathology. And she is passed out, I think, with very good performance. 30, she's finished her, MD and passed out from here because she took pathology. So she knows the standard is very good. People have studied here. The undergraduates know. So basically, a lot depends. See, a lot of people, I told you, a lot of people took rheumatology because they were rheumatology teachers in the, department somehow. It was per chance actually. Earlier than that, maybe one only. But our time, we had a lot of people. Because in command hospital, AFMC, it's a, AFMC has got staff and command hospital. So combined staff can be more also. That can make a difference in the way the subject is taught, what they learn from their teachers. So important. So we move on to our next speaker, Dr. C.B. Mithun, Associate Professor in Rheumatology. Dr. Mithun did his MBBS from Government Medical College Trichure, MD from Government College Trivandrum, Medical College Trivandrum. Then he did his DM from the prestigious JIPMER Pondicherry. He is MRCP, UK, FRCP, Edinburgh. He was faculty in JIPMER. Later on, he moved to our institute. He is a very dynamic clinician and very good teacher and has got very good concepts. He is also a DM and a DNB examiner with a good number of publications to his credit. I request Dr. C.B. Mithun to begin his deliberations.
Very good evening to all. And I know that you are being bombarded with knowledge from the previous excellent talks. And so as not to overburden with you knowledge, I will keep my presentation very simple. And coming to the basics, what is an arthritis? Arthritis means inflammation of a joint. How many joints are there? There are more than 300 joints in our body. Therefore, any inflammation of any joint means arthritis. And you know that there are more than 100 causes for arthritis. Therefore, it is very important to know the cause of arthritis so as to start on correct treatment. Only if you know the reason for arthritis, then only we can treat the underlying disease. And you should understand that arthritis is a symptom, not a disease. It can be a symptom of SLE, it can be a symptom of rheumatoid arthritis, it can be a symptom of spondyloarthritis. And to make the things more simple, the arthritis can be divided into inflammatory and non-inflammatory. Inflammatory arthritis means the reason for arthritis is due to inflammatory disease. Therefore, there is an underlying inflammation. And how we can differentiate inflammatory from non-inflammatory? In inflammatory arthritis, there will be swelling, there will be signs of inflammation or pain, redness. Also, the inflammatory markers will be high and there will be effusion. And whereas in non-inflammatory arthritis, you may not see the signs of inflammation like redness, warmth, and the inflammatory markers may not be high. An example for non-inflammatory arthritis is osteoarthritis, which is a degenerative arthritis. And a example for a inflammatory arthritis is the most common example is rheumatoid arthritis. And as you know, rheumatoid arthritis is the most common inflammatory arthritis in India. And the second most common inflammatory arthritis in India is the spondyloarthritis. Now, what is this spondyloarthritis? How we can differentiate spondyloarthritis from other arthritis? Why it is important? Because the treatment of spondyloarthritis is completely different from other type of arthritis. For example, the treatment given for rheumatoid arthritis, that is the first line is the methotrexate. Whereas methotrexate may not be effective in all cases of spondyloarthritis. It's not as effective as in rheumatoid arthritis. Therefore, the diagnosis to correctly diagnose the patient as spondyloarthritis or to differentiate spondyloarthritis from rheumatoid arthritis is very important. And in this talk, I'll be also just giving you an overview of the basic terminologies and concept related to spondyloarthritis and just an overview of the treatment of spondyloarthritis. And spondyloarthritis is not a single disease. It's a umbrella term used to classify a number of inflammatory disease which can cause inflammatory arthritis, and which are unified by certain common features. The most common diseases which are included in spondyloarthritis group are the ankylosing spondylitis, psoriatic arthritis, reactive arthritis, enteropathic arthritis, which means the arthritis related to inflammatory bowel disease like Crohn's disease and ulcerative colitis. And in children, it can cause, as Dr. Suma told, juvenile idiopathic arthritis, enthesitis related. May have seen, you may remember that picture with Achilles tendinitis. And what is this spondyloarthritis? Why this name came? The spondylitis means there's inflammation of spine. Therefore, the classical feature or the hallmark feature of spondyloarthritis group of disease is the inflammation of the spine. Inflammation of the spine means there are joints in the spine. There may be facet joints, or maybe there will be sacroiliac joints, which is the hallmark feature of a spondyloarthritis disease. Sacroiliac joint means there will be the joint between the sacrum and the ilium, and the hip joint is also included under the axial joints. Therefore, the inflammation of the spine gives this name to the spondyloarthritis. And that doesn't mean that it does not involve the peripheral joints. Spondyloarthritis group of diseases can also involve the peripheral joints like PIP joints, wrist joint, knee joints, ankle joints. Therefore, in the spondyloarthritis are divided into two groups. One is the axial disease, which means in axial spondyloarthritis, the arthritis will be confined to the axial joints, which include the spine joints, sacroiliac joints, hip bones, and the costochondral joints. Whereas the peripheral spondyloarthritis, the predominant joint involvement will be the peripheral joints like wrist joint, knee joint, elbow joints, like that. The classification into these two groups is important because the treatment also differs between these two groups in the spondyloarthritis group. Therefore, the treatment for the axial spondyloarthritis is slightly different from the peripheral spondyloarthritis. Same, the prognosis is also slightly different. Therefore, it is very important to know which is which. And as I told, there are certain common features which unify these group of spondyloarthritis group of diseases. Let's see what are they. The most important is the inflammatory back pain. As I told, the spondyloarthritis, the main thing is the inflammation of the spine, which causes the inflammatory back pain. And not many diseases will cause inflammatory back pain. But as you know, the back pain is a very common feature, is a very common symptom of patients who are attending a OPD. Therefore, it is very important to differentiate the common back pain or the mechanical back pain from an inflammatory back pain. Let's see what are the important features of the inflammatory back pain. Usually, the inflammatory back pain occurs in young persons, usually less than 40 years. And the classical feature which differentiate this from a mechanical back pain due to a disc disease is the morning stiffness. In inflammatory back pain, there will be a morning stiffness. That means when you get up in the morning, the pain will be maximum and it may last more than 30 minutes. As the time passes, the pain will come down. Whereas in a mechanical back pain, the morning the pain will be less. And towards the end of the day, after a heavy work, the pain worsens. That means if there is a morning stiffness lasting more than 30 minutes, it's suggestive of inflammatory back pain. And unlike the mechanical back pain, the pain improves with exercise. Whereas the back pain due to the this disease worsen due to the exercise. And usually these pain, inflammatory back pain is insidious in onset. It's not usually acute. If you have acute back pain, think of a traumatic cause like in a disc prolapse, etc. And it should be to diagnose as inflammatory back pain, the pain should last more than 3 months. Now, what is the cause for the back pain, inflammatory back pain? In spondyloarthritis, it will cause sacroiliitis. Sacroiliitis, as I told, it is the inflammation of the sacroiliac joint. Sacroiliac joint is a joint connecting the iliac bone with the sacrum. And if there is a presence of sacroiliitis, that means that the patient is likely having spondyloarthritis. Therefore, to look for sacroiliitis is very important when you are suspecting a inflammatory back pain. You can see this is the normal sacroiliac joint connecting the sacrum and the iliac bone. Inflammation of this is the normal sacroiliac joint in a plain X-ray. Inflammation cause erosions, as you can see there here, and there is a sclerosis also as a result of inflammation. And later on, due to the ongoing inflammation, this joint can get fused. Here you can see a narrow line where fused. Therefore, it is a grade 4 sacroiliitis. Grade 4 means completely fused sacroiliac joint. Grade 2 means there are erosions in the sacroiliac joint with a sclerosis. And the X-ray changes to appear, it may take some time. Early in the disease, it may not appear in the X-ray. Therefore, there comes the role for MRI. If you have a patient with inflammatory back pain and X-ray doesn't show any sacroiliitis, don't think that there is no sacroiliitis. Go ahead with the MRI. The early sacroiliitis is shown as a bone marrow edema in and around the sacroiliac joint. Therefore, X-ray, if you don't see a sacroiliitis in X-ray, it doesn't rule out sacroiliitis. You need to look for sacroiliitis in MRI, especially in early diseases. And then coming to your clinical examination, how you if you see a case with a suspected sacroiliitis, how you know that it is sacroiliitis or not? You can directly palpate, but as you know, the sacroiliac joint is little deeper, therefore it may not give the not always give a positive result. Then the most commonly done is the Faber test. Make the patient lie down and flex the knee joint, abduct it, then externally rotate. Then you will get a pain. If you have a sacroiliac joint, you get a pain in and around the sacroiliac joint. Then if you get a pain in the sacroiliac joint, then it is called a positive Faber test. If you get a sign on the left side called positive Faber on the left side, if you get a positive on the right side called positive Faber on the right side. And another is a knee to shoulder test, which means you try to touch the knee to the opposite shoulder, you get a pain on the same side of the sacroiliac joint. That means there is sacroiliitis is possible. Then Dr. Suma, you may remember that in Dr. Suma's presentation, he told about the enthesitis. What is enthesitis? It's an inflammation at the insertion of the tendons or ligaments. This is one important feature which differentiate spondyloarthritis from other group of arthritis. For example, if you get an enthesitis, it is most likely spondyloarthritis. You cannot see enthesitis in a patient with SLE or rheumatoid arthritis. The most commonly affected sites are the Achilles tendon and the plantar fascia. This patient will present with heel pain if you have a plantar fasciitis. Therefore, always look for this thing. And this is another important feature. It is called dactylitis. If you get a dactylitis, it is spondyloarthritis unless otherwise proved. Why it is called dactylitis? Dactylitis is the inflammation of the full toe. The whole toe is inflamed. And it is also called sausage disease because of the typical appearance of the toe like a sausage. You can see that the whole toe is inflamed and looks like a sausage. If you get like this, it's a feature in favor of spondyloarthritis. It's another picture of dactylitis. We can see the fully swollen up toes. And this is the another feature of spondyloarthritis is the syndesmophyte, which you can see in X-ray. This is usually seen in advanced cases. What is the syndesmophyte? It is the calcification of the annulus fibrosis of the intervertebral disc. It is shown as some line connecting to the two vertebra. Usually the vertebra you may not see this line, but here there is a disc, and in it is the outer part, there's annulus fibrosis. If it get calcified, it looks like a line which connecting the vertebra. You can see that here the syndesmophytes are formed and then later connecting the two vertebrae and making it less mobile. This is the ankylosis of the spine. As the inflammation goes on, these joints become fused, like in the sacroiliac joints, and these bonds, these vertebrae will get fused and look like a bamboo spine. In the previous this thing is, you can say, it looks like a bamboo spine. It's in advanced cases, and as a result of this fusion of bonds, the mobility will decrease. The patients, what will happen? There will be thoracic kyphosis, and you can see that the lumbar spine, the loss of lumbar spine flexibility, you can, when the patient bends, you can get a straight or flat back. This is a feature of ankylosing spondylitis due to the loss of mobility. And how you test for the spinal mobility? One, you can, if it affects the cervical spine, it will affect the cervical rotation. Look for the lateral rotation or the flexion and the extension. Then you can see for the occiput to wall. See for the difference between the occiput to the wall. And if the thoracic spine is involved, you can see the chest expansion will be reduced. If it is less than 4 centimeter, is said to be reduced. And you can also look for lateral spinal flexion, and most importantly, modified Schober's test. If you get a case of spondyloarthritis in your exam, you need to do this modified Schober's test. Therefore, you should know some. You should know how to do a Schober's test. Let's see how to do it. Ask the patient to stand straight, and then mark a straight line connecting the posterior superior iliac spines. It roughly corresponds to the dimple of Venus. Then measure 10 centimeter above the line and 5 centimeter below. Then ask the patient to bend maximum, and ask the patient to touch the floor without bending the knees. Then again measure these 2 points, and if the difference is more than 5 centimeter, it is normal, and if it is less than 5 centimeter, it is abnormal, and it suggests loss of lumbar flexion. This is very important. Then apart from the articular features of spondyloarthritis, it can also have extraarticular features which have a actually the identifying these extraarticular features is very important because it changes your treatment approach and the prognosis. The most important is the uveitis. Sometimes uveitis may not be present along with the arthritis. When you ask the history, you need to always ask for red eye or blurring of vision, or history of uh, history of any visit to the ophthalmologist, and whether you are given any steroid eye drops. This history is very important, and always look for any synechia formation, which may be the sequelae of a untreated uveitis. And another thing is psoriasis. As I already told, psoriatic arthritis is a type of spondyloarthritis. Also look for or ask for history of psoriasis, and sometimes the psoriasis may not be present at the time of diagnosis. Also look for the nail changes. Also look for the occult site like the behind the ear and the palm, soles, and around the umbilicus. And always ask for the history of any inflammatory bowel disease for the patient, also in the family. And the family history is very important, especially for similar type of arthritis or colitis, or if there is history of family history of psoriasis or red eye. This is very important and gives a clue to the diagnosis when you're seeing a patient with arthritis. And as Ajit Nambiar sir was telling, positive HLA-B27 increases the risk of ankylosing spondylitis or spondyloarthritis. What is HLA-B27? It's a gene. Therefore, there is a genetic, if HLA-B27 is positive, it's a genetic risk for spondyloarthritis. And the positive HLA-B27, the risk is different for different spondyloarthritis diseases. Ankylosing spondylitis, it's a type of axial spondyloarthritis. The positivity of HLA-B27 is 80 to 90%. But you should remember that this can be positive in up to 8% of the healthy controls or healthy population. That means that HLA positive, HLA-B27 positive alone doesn't mean that patient is having ankylosing spondylitis or spondyloarthritis. They need to have other features of arthritis or other features of spondyloarthritis to diagnose them as a spondyloarthritis. And summarizing, in the history, you should ask for a inflammatory back pain, and there, as it's an inflammatory disease, there will be good response to anti-inflammatory drugs, and also look for peripheral arthritis, and also look for the ask for the enthesitis, and look for enthesitis, look for dactylitis. Always ask for a family history of spondyloarthritis and psoriasis, IBD. And preceding infection is important in case of reactive arthritis, which is likely due to some GA infection or urinary tract infection. Look for or ask for history of red eye, which can be a uveitis. Look for psoriasis. Look for ask for history of IBD, which can be a increased frequency of blood in stools. And coming to investigations, HLA-P97 may help in the diagnosis, but remember that negative HLA-B27 does not rule out diagnosis of spondyloarthritis. As it is a inflammatory disease, CRP and ESR can be elevated. And in imaging, you can see sacroiliitis in X-ray and MRI. And there's a brief overview of the treatment. And coming to the treatment, you need to, if you don't treat this condition, patient will become deformed, and the kyphosis there will be loss of spinal mobility, and there are joint damages, including the sacroiliac joint, hip joint, knee joint, and patient will be crippled. Therefore, the adequate treatment is at the early stage is very much needed to control these or to prevent the deformities. And the correct treatment requires non-pharmacological and pharmacological treatment modalities. Non-pharmacological includes the physiotherapy and patient education. A pharmacological treatment, the first line treatment for all spondyloarthritis group is the NSAIDs, which include the non-steroidal anti-inflammatory drugs, which include the diclofenac. It can be atorco, you can use COX-2 inhibitors. No NSAID has documented superiority in terms of efficacy. You can use any NSAID in the correct dose. And the continuous therapy actually retards the radiographic disease progression. This NSAIDs is being regarded as a painkiller, but in this case, in spondyloarthritis group, this is the first line treatment. It's not used as a painkiller. And in continuous therapy can even prevent the joint damage. And if it is not responding to the first line treatment of NSAIDs, in peripheral spondyloarthritis, you can start on conventional disease modifying anti-rheumatic drugs like sulfasalazine and methotrexate. But these conventional DMARDs doesn't have much role in axial spondyloarthritis. That's the importance of differentiating the spondyloarthritis group into axial and peripheral SPA, because in axial spondyloarthritis, these conventional disease modifying anti-rheumatic drugs will not work. In those axial spondyloarthritis groups, not responding the first line treatment of NSAIDs, the treatment is biological disease modifying anti-rheumatic drugs. Biological disease modifying drugs means they are monoclonal antibodies targeted against specific cytokines which plays a role in the pathogenesis of the disease. In spondyloarthritis, the major inflammatory cytokine is the TNF alpha. Therefore, the first DMARD, biological DMARD used in spondyloarthritis is the TNF alpha inhibitor, like infliximab, followed by adalimumab, cetuximab, etanercept. And the recently an anti-IL-7 agents like secukinumab has been come into picture. The first line biological DMARD is considered as the TNF alpha inhibitor. And you may have a question like, what will happen if you don't treat SPA? This picture is self-explanatory. If you don't treat, this will happen. Patient will become deformed. You can see the kyphosis. Patient is walking with a walking stick. If you correctly diagnose the disease, you can prevent this deformity and you can give this patient a good quality of life. Thank you.
Thank you, Dr. Mitran. It was a very nice presentation, I must say. A lot of clarity, and you were able to bring it down to the UG level so that they could, understand the subject very well. So basically, from as a rule of thumb, when you get lower limb arthritis, like you get a patient with, say, ankle arthritis or just one or two joints involved, oligoarticular involvement, and then have low back pain. This is where your mind should always be thinking that what are you dealing with. So upper limb involvement is usually less common. It's what was pointed out so well, spondyloarthritis. And it's very important because, like, there are non-pharmacological management is very important because they have to take care of their posture, they have to do spinal strengthening exercises. That also plays a very important role because everybody may not be able to afford biologics, and so those issues are there. So that point, especially in our kind of economy, we all are dealing with this situation on a day-to-day basis. So that's something which you should always be very clear. Psoriatic arthritis is another entity which you all should be keeping in mind. Sometimes psoriasis may develop later. Actually, the arthritis may occur early and then psoriasis. The skin involvement may occur later. Keep that in mind always. And actually, I'll tell you, it's all a question of basically understanding the basic principles. That is very important. When you get your like hand joint arthritis, like 95% of the time in rheumatoid, hands will be involved. So in the absence of hand joint involvement, hand and wrist involvement, you are calling it rheumatoid. There is 5% chance you will be right, 95% you will be wrong. So these are certain basic principles which should be understood by you. And like you know that there is inflammatory back pain, left knee arthritis, it is more likely to be spondylitis. As Dr. Mitchell pointed out, sausage digit, more common in reactive arthritis, psoriatic arthritis. These are situations where you get. This is something which is very important. And clinical examination, these are things which are very important. You should learn. Don't see. A lot of people think that it is still the most valuable thing. Like if somebody has got hip joint arthritis, internal rotation, that will be one of the first movement to be, there will be pain on internal rotation. Something, which you need to be able to address, understand. And Schauber, as was shown, is a very easy test to do. It's not very difficult. Like cervical rotation, this is lateral, this is lateral flexion, this is lateral flexion, this is rotation, this is extension, this is flexion. So, in like when I was in UK, so they used to have a big protractor. They see the movement, how many degrees. Some places they may be doing regularly. It's all a question of how you evolve. But then the more you are doing it methodically, like finger floor distance. See, and how much can a guy go down? How much can a patient go down? If the disease is worsening, the finger floor distance will increase gradually because he's having less movement. Lateral flexion is reducing. So these concepts, if you understand and think as to why they are there, is very easy actually. It is not there is not much difficulty, to be honest. So thank you, Mitun. It was a wonderful lecture, and I think the best part was you kept it in a very simple way, and that's been the beauty, I think. But because I have been, listening very closely, and I have found that all the 5 lectures till now have had very a simplistic approach and more of perspective, and have kept it to the ground level. And I think the student will definitely, I think, benefit. And I have been told that the number still remains around 700. What do you say? It's still okay. It's just about dipping a little bit to 650 to 700. So we still, like Paramjit, I must tell you that still there are more or less everybody is still there. There may be a few dropouts, but we still have very strong numbers watching this. So now I introduce Dr. Paramjit Singh. He is last but not the least. MBBS from SN Medical College, Agra. MD Medicine from LLRM Medical College, Meerut. Did his rheumatology training at the prestigious AIIMS, New Delhi. He is now the Associate Professor, Department of Medicine, and in charge of the Rheumatology Clinic In addition, he has also been given the additional task that he is the nodal officer of COVID-19. So those who are aware of the job of a nodal officer, I'm quite sure this rheumatology clinic must be a little bit suffering in this situation, because the COVID nodal officer is a very tough task, and he is giving cover to the very large populace in the Kumaon Hills and the adjoining areas of UP. I've had one opportunity and done a camp in Haldwani where he is, with one very senior orthopedic surgeon, and it was a very busy. I remember I drove from Delhi. I started at 5 and I think reached there at about 11 or something, 11:30, and then I remember from that time 11:30 and I had a lunch break of about 15 minutes till 8:30. I was seeing patients, because there were so many people who had come. So it's a very, very busy place. So over to Paramjit, and warm welcome to you from all of us here.
Thank you, sir. Good evening, everybody. I am very thankful to the organizing team of SPUS 2020 of the Amrita Institute, especially to Dr. Colonel Vishal Marwa, Principal Amrita Institute, for giving me the opportunity to have online interaction with you all. I know that you all may be exhausted and you are bombarded with the information and knowledge. So the presentation will be very simple, and as the sir was pointing out that it should be simple so that everybody can understand it. The clinical pulse should be there. The theory is not that important. The experience and the clinical pulse are important. So approach to crystal arthritis. Next slide. So talking about the types of crystal arthropathies, the most common one is the monosodium urate crystals. That is the most common one, and that is, we call it as gouty arthritis. Hyperuricemia is not gout. Uric acid, there may be many reasons for increasing uric acid levels. The simple increasing uric acid level is very common. It may be there in 20% of the US white population. It's not that everybody is having gouty arthritis. Hyperuricemia is different. Gouty arthritis is different. Hyperuricemia may be having many underlying causes, which we will discuss later on. So the patients can have pseudo gout, that is the calcium pyrophosphate crystals, especially common in the older individuals with the osteoarthritis of the knees. Then hydroxyapatite crystal deposition disease may be there. Then there can be calcium oxalate crystals. These are uncommon. We will basically focus on the uric acid crystals or the gouty arthritis. It is the most common and important among crystal arthropathies. It's best understood and most readily manageable, unlike the other chronic diseases like the rheumatoid arthritis and the other connective tissue disorders, which go on for the years or maybe for the whole life. But the good part is that you can treat it very well and the patient may be completely all right without having any disabilities. It is the oldest known form of arthritis, and in the ancient time, it was known as disease of the kings. Why? Because it was there in the affluent societies, because of the use of the alcohol and non-veg that was available to them only. Nowadays, it's common to all. So from a disease of the kings, it has now become disease of the commoners. So it's a health problem around the world. Overall prevalence maybe more than that, 1%. Prevalence is increasing because of this change in the lifestyle and the metabolic syndrome that is there. The prevalence is increasing. It's much more common in males because in females there is estrogen hormone in the premenopausal females, because of the estrogen hormone that is having uricosuric properties. So it's very uncommon to have this gouty arthritis in young females. So it's a dictum. So gout is a signal to search for any underlying metabolic syndrome, obesity, hypertension, nephropathy, alcohol abuse, genetic cause of primary gout, which may be there in some uncommon condition. But if you are finding hyperuricemia in a patient, you should search for the underlying cause. The patient may be having any malignancy. The patient may be having any this myeloid leukemia. Any leukemia can be there because any cause which causes the high cell turnover, because of the this is the disorder because of the purine metabolism. So any condition which give rise to high cell turnover, which will cause hyperuricemia, then the hyperuricemia, if persists for years, as Dr. Vishal and the other speakers were telling, Dr. Mithun was saying that if the condition persists for inflammation persists, that Dr. Vishal quoted Dr. Malviya, that if the inflammation persists for years multiplied by time, it leads to damage. So the same is here. If the hyperuricemia persists for years to decades, it leads to gouty arthritis. So we should search for the underlying cause of hyperuricemia. That is important. So pathophysiology, hyperuricemia is the key biochemical precursor of gout and is the strongest prospective risk factor. Hyperuricemia is defined as the serum uric acid more than 7 in men and more than 6 in female. Although the cutoff is 6.8, at if the uric acid serum uric acid level is more than 6.8, at that level the uric acid becomes supersaturated or saturated, then it becomes deposits or crystallizes above that level, 6.8 level, that is the cutoff. So gout is the most important complication of persistent hyperuricemia for years to decades. So again repeating, development of the gout depends on the degree and the duration of hyperuricemia. That is important. So human purine metabolism, purine synthesis is there, de novo protein synthesis is there. Then we have got dietary purines, and that leads to this body purine nucleotides, and that is in balance with the tissue nucleic acids. And because of that metabolism of the purines, uric acid is there. In the non-vertebrates, there is an enzyme which converts the uric acid to allantoin, which is more soluble, which is excreted. So the problem is uric acid is not there in them because of the enzyme uricase that is not there in human beings. So in the human beings, the renal excretion occurs in by 85 to 90%, and intestinal uricolysis occurs by around 10 to 15%. So mostly it's excreted by renal excretion. So whenever because of any reason by dietary purine overload or any or under excretion, so urate levels the may be high, and because of that the urate supersaturation may occur, as we discussed, like above the 6.8 level there can be supersaturation and crystallization that can lead to the gout or the gouty arthritis. So how it causes the inflammation? As we were discussing, there are various cytokines and inflammasomes are there which causes the inflammation, which activates the cascades, which leads to the release of the enzymes, which leads to the destruction of the nearby milieu. So monosodium urate crystals are there, which because of that inflammation trigger that activates the neutrophils, macrophages, coagulation cascade and complement cascade. So macrophages release the prostaglandins, proteases, interleukin 1, interleukin 6, interleukin 8, and tumor necrosis factor alpha. And neutrophils release the proteases, superoxide, leukotrienes, crystal-induced chemotactic factors, and interleukins may be released. Because of this inflammatory cascade and because of the release of the enzymes, there is swelling, there is inflammation, and later on there can be damage to the this bones, and there can be erosions, just like in rheumatoid arthritis the erosive changes are there. Similarly here in gouty arthritis the erosive changes are there. We will discuss how to radiological differentiate between the rheumatoid arthritis and gouty arthritis. So risk factors, males, because in females, especially in the premenopausal age group, they are protected. Their uric acid level is lower than men because of the estrogen that is having uricosuric properties. So if age is more than 40, with increasing age, the incidence increases. Obesity, as we have discussing, like obesity, then metabolic syndrome, hypertension, ischemic heart disease. All these leads to the increased prevalence of the gouty arthritis. If family history is there, especially in the hereditary causes, it may be there at the younger age group also. Then the use of alcohol and non-vegetarian diet, that is very important, because the beer and the spirits or the alcohols, they are having high purine content, especially the guanosine is high in the beer. So the most propensity of having the gouty arthritis is with the beer. If you want to have alcohol, it's better to have wine rather than beer, because beer is having this highest guanosine content. Then in the purine rich diet, especially the non-vegetarian diet, red meat and fish, and contrary to that, the purine rich vegetables, although they are having purine, they are purine rich, but they are not causing the gouty arthritis, because that purine may not be bioavailable to that extent because of that. The legumes and the nuts, all that. Then sugar and sweetened drinks like soft drinks. Then if the patient is having renal insufficiency, the clearance may be low. Then the drugs like diuretics, especially the thiazide diuretics. Then we have got low dose aspirin, like specially given to the patients who are having coronary artery disease. Then in the anti-tubercular agents, pyrazinamide, then cyclosporin, the patients may be having maybe on the levodopa. Then all these conditions, especially the psoriasis. Psoriasis is also a condition which with high cell turnover. What happens in the psoriasis? There is a rapidly change of the skin cells. Because of that, there is a rapid cell turnover. Because of that rapid cell turnover, there is a metabolism, and that leads to the hyperuricemia. I remember a patient who was around 50-year female. She was from that the foothill Katgodam area, that is the foothill near the Nainital, just at the foothill. She was having swelling and the pain in the ankle, and she was seen, and she was having undifferentiated arthritis at that time. It's important. The importance is that we should follow the patient in time. The diagnosis changes with time. It's not we are not sure of the diagnosis at the first visit. In rheumatology, you have to serially follow the patients. It's not that at the single visit or the first visit you will be able to make the diagnosis. You may be wrong. So a diagnosis of inflammatory arthritis was made. She was given anti-inflammatory treatment, and after a few weeks she visited United Kingdom, and there she visited some hospital, and she was diagnosed as having gouty arthritis because her uric acid was high. And she was there for a few months, and later on she returned here again. Then after returning here, she came to me, and at that time I noticed that she was having skin lesions. So the sir was telling that the arthritis may precede the skin lesions. So she was having typical skin lesions consistent with this scaly type of skin lesion consistent with the psoriatic arthritis. So the diagnosis was revised to psoriatic arthritis. Initially inflammatory arthritis, then gouty arthritis, then psoriatic arthritis, because initially she was not having any skin lesions. The arthritis may precede the skin lesions. So the final diagnosis was psoriatic arthritis. Because of the high cell turnover, the uric acid may be high. So that's why she was labeled as gouty arthritis. It's not the fault of the physician that was there in the United Kingdom. It's the disease course, because the disease evolves with time. So it's important to follow the patient with time, and the disease can be revised accordingly. So it's not that the uric acid is all bad for us. It's a most abundant antioxidant in the human body. So above 6.8 milligram per deciliter, it started saturating, and then it can crystallize if hyperuricemia persists for a longer time. So already we have discussed that it's very common to have hyperuricemia. It may be there in the 20% of the adult white men in the USA. The hyperuricemia may be subclinical. The patient may be having this hyperuricemia, but the clinical features are not there. So persistent hyperuricemia for months to years may lead to the clinical gout. That is the gouty arthritis. So that is the typical presentation of acute gouty arthritis. it's very important to remember the one word, that is the episodic attacks. That is very important. The most important word is the episodes are there. The patient was completely all right. He had some party in the night. He had some alcohol and non-veg. And when he wakes up in the morning, he's having very severe pain at the first metatarsophalangeal joint. There is swelling, there is redness. He's not able to walk. So that is the typical presentation of acute gouty arthritis. It's very typical. So maximum intensity of pain is at 8 to 12 hours, and it's very severe excruciating pain. The first attack is acute, the explosive onset is there, and most of the time it's monoarticular inflammatory arthritis, and the most commonly involved joint is first metatarsophalangeal joint. Two words or two things we have to remember. It's episodic. Unlike the rheumatoid arthritis, in rheumatoid arthritis, inflammation is persisting. The patient may start with a pain and swelling at a single joint or few joints, and later on there is additive involvement of the other joints. With time, the inflammation increases and the other joints are added on. But with the gouty arthritis, there is an episode, and after that the patient is completely all right. Maybe after acute attack, after 5 to 7 days, the patient is completely all right. The patient may not be having any symptoms. The patient is completely all right unless the patient has second attack. Depends on the dietary habits and the lifestyle and the underlying medications. The patient may be having second attack after months to years, depending on the condition. So the other joints that can be involved, in most of the cases, whenever the patient is having first attack, in around more than 50% of the cases, it's the first metatarsophalangeal joint to start with. And later on, if we see overall the incidence of the involvement of the first metatarsophalangeal joint, there may be other joint involved also, like the heel, ankle joint, knee joint, wrist joint. The other joints may be involved, and there is a variety which is called as polyarticular tophaceous arthritis, which is just like rheumatoid arthritis. It may involve the hand joints also. So you have to remember episodic attacks, first metatarsophalangeal joint, and the typical history, that is very important. The patient wakes up in the morning, had party in night, and is having very severe pain, and that may persist in the natural history, may persist for 5 to 7 days or a week, and after that the patient is completely all right, and after a few months the patient may have a second attack. So episodic history is very important. So this is, the patient can have, although it's not common. So this is chronic tophaceous gout. These are tophi, if you can see. These are deposits of the uric acid, or uric acid crystals have been deposited, and there is inflammation of the soft tissues. And at times you may see that there is a oozing of the this chalky white material may ooze from these. That is, urate crystals may ooze from these tophi. So this is polyarticular gout. Time interval may take decades. Maybe that's average, maybe more than 10 years. If that hyperuricemia and this inflammation persists, then the patient develops this type of tophaceous gout, polyarticular tophaceous gout. So persistent low-grade inflammation may be simmering inside, and joint damage and deformities occur because of the erosive changes that are there, just like in rheumatoid arthritis. So these deformities may be there. So acute attack is more frequent, repeated acute attacks are there, and later on the patient can have this chronic gouty arthritis, or and even the chronic tophaceous gouty arthritis. So tophi may be there at the other sites also, just like this subcutaneous tissues. Especially it's important to examine this site, just like the behind the pinna. It's very important. At times the polyarticular variety may mimic with the rheumatoid arthritis. If you get a tophi in the subcutaneous tissue behind the pinna, as I attended a talk by Dr. Malviya, he was saying that he just got a patient who was mimicking rheumatoid arthritis, and but just he noticed that there was a subcutaneous tophi at the back of the pinna. So he was sure that this is nothing but gouty arthritis. So that's the importance of having this clinical examination of the patient, just like in that patient of psoriatic arthritis. So it may be there at the heart walls, myocardium, it may be there at eyes, but it's very unlikely. Like it may be there at the bursa around the knee, dorsal aspect of the toes, Achilles tendon. All these sites are there for the deposition of these crystals and the formation of tophi. So evaluation wise, the diagnosis is always clinical. Episodic history, the typical involvement of the first metatarsophalangeal joint, or there may be other joints also like oligoarticular asymmetrical involvement is usually there. It's very uncommon to have polyarticular this tophaceous gouty arthritis. So first and foremost is the demonstration of crystals. That is very important in the synovial fluid examination. My first exposure of rheumatology was at the workshop at R&R Institute in New Delhi, where Dr. Vishal was there and Colonel Bhakuni was also there. This was my first exposure in Delhi about rheumatology. After that, I had an opportunity to join the senior residency at All India Institute of Medical Sciences. So I attended that workshop, and I also attended that workshop on the intra-articular injections. So after that, I was attracted towards rheumatology, and I did my senior residency in rheumatology. And here at in Haldwani in the Kumaon Hills of Uttarakhand, I started the rheumatology clinic. So this was the first exposure. So it's important to aspirate the joint from that synovial fluid. Just Dr. Ajit, he was telling about the differences between the synovial fluid. Inflammatory synovial fluid is watery, unlike the normal synovial fluid, which is very viscous. So sting sign is there. So when the fluid becomes viscous, it becomes watery. The viscosity is lost. So we can demonstrate the crystals in the, it's not under normal microscope. We can demonstrate it under polarizing microscope that we will see later on in the photograph. So if a patient is having single joint involvement that is having inflammatory feature, first and foremost, we should rule out the infection because the treatment is altogether different. The patient may be having septic arthritis. So for septic arthritis, the treatment is altogether different. You have to give the antibiotics. You have to aspirate the joint. The joint toileting may be required. So, and in gouty arthritis, if the crystal load is high, you can get the typical chalky white material or milky, this urate milk may be aspirated. So it's important to examine the synovial fluid for the crystal analysis for the gram stain culture sensitivity, especially to rule out the septic arthritis because it's a dictum. If you are having a inflammation in a single joint, it's warm, tender, you have to aspirate the joint, you should rule out the septic arthritis. And it's preferable to demonstrate the crystals, that is confirmatory for gouty arthritis. Then X-ray findings may be there, like we will see the picture. The erosions are there, and how to differentiate it from the rheumatoid arthritis erosions we will see. So it's important to rule out the trauma. Serum urate levels may be normal during acute attack. That is the very important point. The patient may be having severe pain and swelling. You are clinically suspecting that this patient is having acute gouty arthritis. You order the serum uric acid level, it's in the normal range. What to do now? You should remember that serum uric acid level may be normal in around 40 to 50% of the patient during acute attack. So you have to treat the underlying condition. You should repeat the serum uric acid levels after 5 to 7 days when the acute attack subsides. That's the importance to have a follow-up of the patient, and serial uric acid levels are important. So it's important to remember episodic attacks are there. Most common involved joint is the first metatarsophalangeal joint, and uric acid levels may be normal during acute attack. It's the serum level we are measuring. We are not measuring the levels that are there in the synovial fluid. So leukocytosis may be there, raised ESR may be there, raised CRP may be there, as occurs in the other conditions, other inflammatory conditions. And we should always rule out the underlying myeloproliferative disorders. Why? Because there is high cell turnover. Patient may be having underlying leukemia, and because of that, the uric acid level may be high, and that can lead to the gouty arthritis. So it's important to remember to have aspiration and to look for any underlying condition, especially in the younger age group. Hyperuricemia may occur with the underlying chronic renal failure. So dose modification of the medications or the drugs may be required with the hepatic and renal failure, depending on the GFR and the levels of the liver enzymes. So demonstration of the monosodium urate crystals in the synovial fluid or the tophi by polarizing microscope is very important. It's the most important diagnostic test with sensitivity of 84% and a specificity of 100%. At AIMS, we used to have some attachments with a microscope, and with that we will try to look at the uric acid crystals. If you see the uric acid crystals by your own eyes, you will remember how they look like. So these are the needle-shaped crystals negatively birefringent. So with the polarizing microscope at perpendicular directions, they may be having different colors. So either the FNAC may be done from the tophi, or you can aspirate the fluid. And even in the asymptomatic patients, the synovial fluid may demonstrate the crystals, because hyperuricemia may be persisting, but it's not clinically manifesting. So even then the patients can have the crystals in the joints. So this is the aspiration that we were talking about, the milky fluid or milky urate. So that is the typical of the urate crystals. High concentration of urate is there. So milky white fluid, urate milk. Serous sanguineous fluid is there. Viscosity is poor because of the inflammation. Gram-Messner culture is negative. Monosodium urate crystals are there. Glucose is normal. So this is the typical appearance. So this is the under polarizing microscope. You can see that these crystals are there. Needle-shaped crystals are there, and at perpendicular direction, their colors are different, bluish in color, and this is yellowish in color. So at the orientation. So at the different orientation at perpendicular direction, their color is different. Some are intracellular, some are extracellular. So because of the phagocytosis, these may be intracellular crystals also that triggers inflammation. So typical picture of needle-shaped crystals. So this is the imaging. The imaging, you can notice that severe destruction of the first metatarsophalangeal joint, and there is soft tissue swelling that you can notice. And if you are able to notice, there is a erosions with overhanging margin that you can notice. The cursor is there, overhanging margin, that is typical. This overhanging margin, this is typical for this gouty arthritis. Joint space is preserved, unlike in rheumatoid arthritis. In rheumatoid arthritis, what happens? There is carpal crowding at the wrist. If you see at the wrist X-ray, there is a radiocarpal space is reduced, intercarpal space is reduced. So carpal crowding is there, space is reduced. But in gouty arthritis, the space is preserved, and you can notice this typical erosions with overhanging margin, with typical this finding is there, and soft tissue edema is already there. So it's important coming to the diet, which diet one should take. So hydration is important because hyperuricemia is already there, and because of the intra-articular dehydration, and because of the change in temperature. Why the first metatarsophalangeal joint is involved? Because it's at peripheral joint, the temperature may be low, and there may be intra-articular dehydration. Because of the dehydration, there is a precipitation of the crystals that leads to the inflammatory cascade and the inflammation and the clinical picture of acute gouty arthritis. So to maintain hydration is very important. Green vegetables intake is very important. Although some green vegetables like legumes may be rich in the purine content, but vegetable purine content is not that should not be restricted, because bioavailability is less and they are permissible to these patients. Fruit and cherries should be encouraged. Low fat dairy products, that is a misconception among some patients, like milk and the dairy products increase the uric acid levels. So low fat dairy products should be allowed. High fat dairy products should be avoided, like skimmed milk should be taken. High fat dairy products should not be taken, but low fat dairy products are allowed. Vitamin C rich fruits are allowed. Artificial sweeteners or soft drinks should not be taken. Nuts and the coffee, they are also associated with the decreasing uric acid levels. So diet is very important. Every patient or the general public is very aware. They ask about, there may be some misconceptions just like the milk and the dairy products. So one can have the low fat dairy products. Just like there is a misconception that anybody having any pain in any joint, the patient correlates with the uric acid levels. They go to the lab and by their own they get the uric acid levels and they make their diagnosis that they are having the high uric acid, so they can start the allopurinol. So this is the misconception. Just like here in our area, it's very common to have anybody having fever. They test for the Vidal test. It's positive, although it's amnestic reaction or it's low titer. They will say, you will ask the history, what is your problem? They will say, I am having typhoid fever. They won't tell you the symptoms. They will tell you that they are having typhoid fever. Sir, give me the treatment for typhoid fever. Just like here, every pain is not because of the uric acid. There are other causes also. There may be mechanical pain. There are other many hundreds of the causes of the joint pain. It's not the uric acid that is leading to the that is leading to the joint pain. And simple hyperuricemia, asymptomatic hyperuricemia should not be treated. And the patient and some physicians may be giving them the uric acid lowering agents. Simply they are having the xyloric, allopurinol. So general approach, one should look for the underlying causes or the reversible factors or the risk factors that are there, just like non-vegetarian diet, alcohol, or the underlying hypertension, or the patient may be having obesity, should reduce weight. Lifestyle changes are important. The patient may be on certain medications like thiazide diuretics, or the patient may be on certain other medications like any low dose aspirin, pyrazinamide. So that should be looked on. Patient should lose weight, and this non-vegetarian diet should be avoided. Alcohol should be avoided altogether if possible. And one can have the low-fat dairy products. That's important. So general approach to the management of gouty arthritis, as sir was telling, that any patient with acute gouty arthritis doesn't need the allopurinol or xyloric. The patient needs, because it's an acute inflammatory condition, the patients need anti-inflammatory agents simply. So NSAIDs can be given simply. You can give indomethacin, you can give naproxen and diclofenac for 5 to 7 days. The patient is completely all right. The corticosteroids may be given for a short time. Oral can be given. It can be given intramuscular depot preparations, which we can very commonly give, or we can give the intra-articular injection. The particular joint is there. Suppose the patient is having swelling in the knee joint, inflammation is there. We can aspirate the joint. We can have the look at the synovial fluid grossly, and we can even test for the crystals, and we can give the intra-articular injection. Simply dipomedrol or the methylprednisolone depot preparation can be given, or triamcinolone can also be given. 80 mg for the large joints, and the 40 mg for the, or even 10 mg for the smaller joints. Colchicine can be given for the treatment and prophylaxis of the acute attacks. So indomethacin, most widely used NSAID, may be given 75 milligram daily, 25 milligram thrice daily, or 75 milligram once daily. Diclofenac, naproxen. Naproxen is preferred in patients with coronary artery disease. Duration 7 to 10 days. Contraindications, as with the NSAIDs, renal insufficiency, if the patient is having peptic ulcerations, congestive heart failure, hypersensitivity to NSAIDs, anticoagulant therapy. Then corticosteroids, when NSAIDs and colchicine are contraindicated, if there is insufficient response to NSAIDs, then corticosteroids can be given orally or intra-articularly. Likewise, depending on the size of the joint, the dose can be adjusted. Colchicine is for the treatment as well as for prophylaxis of the acute attacks. The dose is available 0.5 milligram tablet. So 1 milligram initially, and after that you can give repeat doses depending on the response and the adverse effects that may be there. So you have to watch it for the adverse effects, especially the GI adverse effects, and injectable should not be given, only orally should be used, that is safer. Injectable should be avoided. So diarrhea, vomiting, hemorrhagic gastroenteritis may be there. On long-term use, bone marrow suppression can be there. So you should monitor the patient for CBC, liver function test, kidney function test. So single attack of the acute gouty arthritis should be treated by the this anti-inflammatory agents. If a patient is having repeated attacks, especially if a patient is having more than 3 acute attacks of arthritis in a year, then you should think in terms of giving the patient the uric acid lowering agents for a long term basis. Otherwise, if the frequency is less, you treat the acute attack. You can give the colchicine for few weeks. There is no need to give the uric acid lowering agents. Uric acid lowering agents or the treatment for the chronic gout is indicated if the patient is having chronic tophaceous gouty arthritis, if radiological erosions are there, if urate calculi are there. Then commonly used medications, allopurinol or is active metabolite oxypurinol. Then the febuxostat, it's a selective inhibitor of xanthine oxidase. It's preferred in patients who have got mild to moderate renal failure. And losartan and fenofibrate. If a patient is having hypertension and having hyperuricemia, losartan can be preferred because it's having uric acidic properties. It lowers the uric acid levels. Then the patients who are having hyperlipidemia, it's very common to have hyperuricemia with hyperlipidemia or dyslipidemias. So you can give the fenofibrate. It also lowers the uric acid levels. So these can be preferred. So allopurinol is given in patients with urate overproduction, tumor lysis syndrome, then uric acid nephropathy. If there is allergy to uric acidics, and dose is 50 to 300 milligrams per day, single morning dose, and dose can be modified according to the creatinine clearance. And in the patients with the moderate renal failure, the patients can have the febuxostat. There are newer drugs, especially these are costly agents for the refractory cases than the uricases. Just like the natural uricase is there in non-vertebrates, then the pegylated uricase is there, pegloticase. IV infusion 8 milligram is given. Then we have got uricase urics like lesinurad, then Bons bromeron. Then we have got interleukin 1 antagonists like anakinra. These are costly. Interleukin 1 beta monoclonal antibody canakinumab. Subcutaneous injections are given, especially for the refractory cases. Then to summarize, gouty arthritis, or it's the most common crystal arthropathy or arthritis, is very common, and prevalence is increasing because of the changing lifestyle. Increasing longevity and prevalence of hypertension and diuretic use and end-stage renal failure and dietary trends and the metabolic syndrome is the main cause for increasing prevalence. So it's very simple to diagnose, very easy, simple. The patient is having acute attack, episodic history is there. The patient is having involvement of 1 or 2 joints, especially the first metatarsophalangeal joint. The patient wakes up in the morning, typically having very severe pain, swelling is there. The patient may not be having other features. The uric acid level may be normal. So it's very easy to diagnose, very easy to treat, and the patient may be completely cured of it. If the patient takes care of his lifestyle and takes proper treatment, it can be cured also. Unlike the other chronic rheumatological conditions. So asymptomatic hyperuricemia needs no treatment. Like it's their misconception in the general public. If the uric acid is 7, they start allopurinol. So asymptomatic hyperuricemia should not be treated. We should look for the underlying condition. The underlying condition should be treated, just like you may be having dyslipidemias or hypertriglyceridemia may be there. So hypertriglyceridemia should be treated. Automatically there will be correction in the uric acid levels. And Uric acid level may be normal during acute attacks. That is very important to remember. So you should check again the uric acid levels when the patient becomes all right after a week or so. So we can again check the uric acid levels. So thank you very much. So I again thank you the organizing team for giving me an opportunity for this talk, and I am very indebted especially to Principal Sir. Thank you, sir.
Thank you, Dr. Paramjit. It was a wonderful lecture, and I must say the topic was covered so beautifully, and you were able to bring out all the important nuances for the basically epidemiological, diagnostic, and therapeutic aspects were very well covered. And as I had told, which you will agree with me because you are running a rheumatology clinic, many patients are given allopurinol as the first line of treatment in acute gout along with NSAIDs. And so I think as a first, I think most important take home message, which I think all the students must never give allopurinol during an acute attack of gout. If I think today one major lesson you have learned from this talk, I think that will be a very important thing. The second was the episodic nature, which he brought out repeatedly. Dr. Paramjit brought out very well the episodic. So it is something and great. If somebody is having recurrent first MTP joint arthritis, is a male above 45, 50, and if you look at the history, there's some alcohol, non-veg intake, more or less you are like sure that the diagnosis. And milk and all, don't stop. Milk you can take. What sir was saying very nicely that, a lot of people say, don't take milk, dal and all this. No, that's a wrong advice giving to the patient. Ask them not to take organ meat, non-vegetarian food, alcohol, and not to smoke. That is important. Stopping milk, stopping pulses is a wrong thing because I'll tell you why. Once there was a friend of very close friend, Dr. Paramjit also knows Dr. Grover.
Yes, yes.
Rahul.
Yes,
So Rahul, Rahul used to tell very, very, he says, sir, in a vegetarian, they don't take meat and this, and you stop milk and pulses also. Then where are they going to get protein from? So then you want them to eat only roti and what sabzi. That is all. Then it is not good. For the you're not able to provide a balanced diet. So it is very important. Once I sent one patient, to a dietitian who stopped all this. After that, I never sent that patient to the dietitian. I advised myself because, and the milk, there is a big study, Choi et al., where they say that actually milk brings down the uric acid. So stopping milk is a wrong advice to yes, low fat milk, that is better because of the obvious reason. Because you want to reduce cholesterol intake. Those logically are correct. So I think these are the important points which I think all of you should keep in mind. So as we close, I think we'll request all our team to be, come and you can meet everyone. Actually, Dr. Paramjit is, I think, here. Arindam is there. Arindam is there, one of our key persons in the 2017 batch. He has done a lot of work. And Sri Hari, then these all people are behind the scene. Can you, and I request the team to please come so that we can have one, final closure. Yeah, Arindam is, I think, there. So there are a lot of unsung heroes like Arindam and who are behind the. There are many Krishnan and all. Like, who all, so then Anuja Jayan, our organizing. I think one sir, aap idhar aa. So here is the team. I can just, I don't have to introduce Dr. Ajit Nambiar. He already spoke, so you know
yes,
him.
yes, yes.
Yeah, and here we have Srikant. He's the Srikant Shyamkumar is the organizing secretary. The co-organizing secretary is Ashwin Pillai, Ashwin Rajiv Pillai, right? To be precise. Then we have in the organizing committee John Joseph, who's here, is going long hair, a little different from the others. Our good friend Yatish Reddy, he is, the from the 2018 batch. He's one batch junior to the 17 batch, and they are some of the key people because of the COVID. Unfortunately, I'll tell you, unlike last 2 years, this is the third edition of Spasht. Now, what I see, We don't have many people on ground. It's only them, and I'm also not allowing them to come very often. So like I'm telling them, just come on the key days, and we're doing everything is being done online and telephonic, and everybody working from his home, and so but it's still we are happy that we could the 2 weekends are now near, coming. Tomorrow will be the it will come to an end. The second, and I think the progress has been pretty good. And we got a viewership of something like 1400, 1200, and today was also above 700. And another thing is that many people are watching it on the YouTube. That's what I have learned. Many have asked me. In fact, I have given the link. So many people said, please share the link. In fact, my school group I had not put. Somebody put it there. Then I got about 20 odd congratulatory messages that it was one of the very good debates. So I can just say that it's coming out very well, and I think we are grateful to our Sadguru Mata Amritanandamayi Devi, because without her blessings and grace, it's just not possible. Even when I look back, because I moderated 3 sessions last week, I was also very tired actually by the end, running up to this, and then actually at that time I was thinking I made a technical mistake. I should have one was co-chaired with Dr. George. So, I was thinking that I should not, but then, I think our Sadhguru Amma's energy actually probably drives us to, move. And like Dr. Ajit wanted to, he was telling me that he was saying somebody else would speak today, but I insisted that he speak. And I don't think this today's webinar on rheumatic could have been that good if Dr. Ajit Nambiar had not spoken. So we are very grateful that he agreed. Dr. Paramjit Singh again was very good. He done very well in Delhi. I know the kind of reputation he had, and we have a common teacher, Professor Ashok Kumar, and Professor Rohini Handa, and Dr. Rajiva Gupta, some of the best. And then our own grand teacher is Professor Anand Malviya, whom I quoted about, like I still remember one point, which Dr. Paramjit highlighted, that if somebody's uric acid is high, is asymptomatic, think that metabolic links, he may be having something. So I remember he said that somebody's uric acid is 10, but there is no arthritis. Remember, uric acid raised is like a chowkidar who is telling you, sir, there is something wrong. So, and now what you do, you just slap or you just shout at the chowkidar, and bloody, you go to hell. And that's what happens when you give allopurinol. So you haven't looked at sedentary lifestyle, you haven't looked at diet, you haven't looked at obesity, nothing. But you just gave 200 milligrams or 300 milligrams of allopurinol. You want to bring the uric acid low, but you haven't looked as to why he developed hyperuricemia. So this was something which I learned from our teacher, grand teacher, Professor Anand Malviya. All of us are hugely influenced, and today, in fact, even Brigadier Shanmugananda, these are very, very inspiring people. They are all very good clinicians. I have learned a lot from him. He's an astute clinician. And even as a professor, he used to stay in AFMC. His house will be about 1 kilometer from the, any case comes in emergency, and his anything is wrong, the trainee will tell him, he will go at night, middle of the night, he will go and see the case. He's got that kind of, personality. He's not somebody who will talk, he'll go and see the patient on ground. And that's what we learned from them. And I'm grateful that we got the right kind of thought process. So I think, like to say something. Paramjit, like to say something?
Yes, sir, it was a wonderful, basically your team has done a wonderful job. It was great to join your team, and you all are doing a very good job. By this, in the COVID era, you are having this type of talks. It was also useful for me. I have learned few things. I have attended 3 or 4 lectures. I have also revised the things, and I have also been able to learn few things. So it's very good that this SPUS 2020 team has organized this in a very wonderful way. Thank you all. You need applause.
Thank you, Paramjit. And Dr. Suma Balan, I think a lot of people would understand what pediatric rheumatology is. Actually, I have learned here, after coming here the first time, I've worked with a pediatric rheumatologist. And I realized that what a difference it makes. Otherwise, you will never really get. But if you're taught by people who don't know that much of pediatric rheumatology, it will just be a pretty average kind of affair, and you'll be, sort of, so getting taught by the right people is also very vital. Dr. Mithun was also on, and he made the topic look very simple. Earlier on, Dr. Bimlesh Pandey, again, he's a very learned man, and he's somebody who is actually not teaching undergraduates. Like all of us are here are dealing with UG, but he's somebody, even Paramjit is a UG teacher, and Mithun is a UG teacher, so also Suma ma'am and all, but he's in practice. But I think the way he taught SLE, I think he really knew how to come down to the level for the UG. So I'm very glad. So I'm sure those who have not seen can probably look at the videos. I think the last, because our previous one also I saw the YouTube. Many people have seen, and many have asked us for the. So saying that with keeping our Sadhguru in our mind, and I'm sure that with Amma's grace, the 2 weeks are now coming to an end, and I'm sure the third week will also move on. The basic idea is that there should be some development, some progression in the mind, and there's exchange of ideas. We were getting some questions. We could ask a few. We'll try to reply them as the time was a little constrained, so I had to limit the questions. The questions were many. I had to ask only few. So anyway, thank you very much on behalf of all of us here.